afternoon, everyone. Good afternoon. I'll say good afternoon mainly. Good evening and good morning, depending on where you are in the world and you're watching later or not. Thank you for joining. There's room for more. Get more people to join on. Remind them. I know it's a lovely Saturday afternoon, but we have important information to share with you today. So get them on. So this afternoon, Gintavenes Health Foundation, in collaboration with Victory Drugs and Encapsulate Healthcare Solutions, we're bringing you a cancer awareness webinar on prostate and cervical cancer. That's the topic we're covering today. We had part one a few weeks ago that can be found on our YouTube channel. We'll pop the link to that one in the chat later on today. Without further ado, I am going to invite the founder of Gintavenes Health Foundation, Dr. Andrew Angu, and he's going to give us a welcome.
Good afternoon, ladies and gentlemen. Welcome to yet another health education and public enlightenment programs. This is our second version of the cancer series. Today we'll be dealing with prostate, cervical cancer, and also telling you what oncology is and who should be administering chemotherapy, especially in Nigeria. We'll welcome you and we hope you'll be able to stay all through the meeting. On behalf of our ardent supporters, our board of trustees, and indefatigable facilitators, we say welcome. Our project manager, Mr. John Nsangbedo, will be telling you how to donate to help us do more of these and the other projects that we'll be carrying out. Thank you for joining, and do share the link so that other people can join and people will be informed and prevent themselves from developing the diseases and seek help early if necessary to prevent themselves from dying from these mostly preventable conditions. I'll now hand you back to our able moderator, Ms. Flora Coker. Thank you for joining.
Thank you for that. Thank you. Okay.
Thank you, Flora. Welcome, everybody. And our first speaker is unfortunately absent, but she did give a talk at my last meeting. I will be playing her video for you all so that you know what oncology is and who should be administering oncology in Nigeria.
So yes, just a bit more.
In a minute.
Yes, just a bit more about our first speaker. Dr. Iwuji is a consultant medical oncologist who worked at the University Hospitals of Leicester until her move to Lakeshore Cancer Center in Lagos, Nigeria. She qualified from Southampton Medical School and holds a degree in physiology from the University of Dundee. Her postgraduate qualifications include a master's degree in oncology from the University of Nottingham and a PhD following her research investigating the use of curcumin in the treatment of colorectal cancer. She works with Africa Partners Medical and Jos Hospital, Nigeria University Teaching Hospital, to teach oncology and communication skills in their continuing medical education program. She's a member of the steering committee for the Royal Society of Medicine's Global Cancer Care Program. She's also the president of the British Nigerian Oncology Group. So we'll just share her presentation now.
Start off by sharing my screen. So, okay, can you all see my screen?
Yes.
Okay, great. So thank you, everybody. Like I said, it's a pleasure to be here and to be part of this presentation. I am Dr. Chinenye Iwuji, as was said. I'm the head of medical oncology at Lakeshore Cancer Center in Lagos, Nigeria. What I'm going to be talking to you about today is oncology and what we need to know. So I'm really just going to run through the basics in terms of helping us understand what is a cancer, how do we diagnose cancers, how do we treat cancers, who are the specialists that we should actually be seeing to get the treatments for cancer? And of course, what everyone worries about with cancer treatment is the side effects. What are the potential side effects and how can they be managed? So, right. So what is a cancer? Essentially, all the normal cells in our body are going through a cycle whereby they're born and then they specialize into the particular type of cell they're going to be, whether it's a breast cell or a lung cell. And then whilst they've been working as those cells for a while, they then die off. So there should be a normal cycle for all cells in our body where they're born, specialize, and die. But what tends to happen with cancer is that these cancer cells are born, but they don't really tend to specialize that much. They just keep growing, 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 and then they don't die either. So when these cells are not dying, they then go from being normal cells to abnormal cells. They multiply really quickly. They turn into masses or tumors, and then they can also do what we call metastasize. So metastasizes means that they have spread from wherever they started to other parts of the body. So for example, if you have a tumor that has started in the kidney, it can then grow and then spread via the bloodstream or via what we call the lymphatic system and infect or send seeds to other parts of the body like the lungs, the liver, the brain. And when we start seeing the effect of those tumors growing in other parts of the body, that's when we start getting symptoms of the cancer as well. Or we might sometimes get symptoms of the cancer when it's still localized in the place that it started from. When you have a cancer, you might get symptoms of the cancer. So you might get symptoms such as pain. You might notice a swelling somewhere in your body. You might get weight loss or feel very abnormally tired. It depends on where the cancer is. So for example, if you have a breast cancer, you might notice a breast lump as well. If you have a prostate cancer, you might notice difficulty in passing urine. And I think my colleagues might go through this in a bit more detail when they're talking about specific cancers. So when you have those kind of symptoms, you should go to a doctor to get investigated. Or even better yet, if you attend a screening program, then it's easier to catch the cancer early on before it starts developing symptoms. So screening is basically when we get our health checkups done in advance so that we can catch things like cancer at a very early stage, and then it's easier to treat the cancer. So when you're either having screening or when you have symptoms, we then like to do things like imaging. So that's when we can have a look at the cancer. And the kind of imaging we do depends on what kind of cancer we're suspecting. So for example, if you have a lump in the breast that we think is suspicious, you might have an ultrasound scan or a mammogram, which is like almost like an X-ray or a type of way of looking at the breast in more detail to see if there's a lump there. You might have an MRI scan, which can look again at that particular part of the body in a bit more detail. A CT scan is always, well, generally extremely helpful when we're trying to diagnose cancers, but also when we're trying to stage the cancer. So like I said, if we want to know that whether the cancer is still in the place that it started from, or whether it sends these seeds to other parts of the body, then a CT scan is extremely helpful. And then finally, you might want to do a PET scan. So PET scans, thankfully, are now available in Nigeria. But we have to be careful when we do these PET scans. So PET scans can be helpful in identifying whether the cancer has spread to another part of the body. But just because you have a cancer does not 100% mean that you need a PET scan. It should be your doctor who's a specialist that will tell you when you need to do each of these scans and when it's most appropriate to do them. If we do find something that looks suspicious, like it might well be a cancer, then we want to get what we call a biopsy, which is basically when we go in and take a sample, like a tissue sample from the lump or the tumor that we have found. And then we do a process called histology, which is when we look at those lumps under the microscope to confirm, is this really a cancer? Because sometimes it's just because you have a mass does not mean you have a cancer. For example, with ladies who have breast lumps, they might have, the lumps might be things like lumps of fat, for example, lumps of tissue. It does not mean that just because you have a lump or what looks like a tumor that you necessarily have a cancer. And sometimes even when we do find out that that tumor looks suspicious for a cancer, we might want to do extra tests called immunohistochemistry, for example. And that will help us, number one, confirm the type of cancer that we think this is. And number two, classify that cancer into a particular subgroup so that we know exactly how to target the treatment that we're going to give to the patient. And so what are the types of cancer treatments that we have? Well, we tend to generally divide our cancer treatments into localized treatments versus systemic treatments. So localized treatments are things like surgery or radiation therapy, and then systemic treatments are all the other ones listed here. So I'm just going to go through them in a little bit more detail. So surgery is a bit self-explanatory. That's when you find a lump or a tumor, and then you go and do surgery to take that tumor out. Radiation therapy is when you, for want of a better word, you zap the cancer. So you can see where the cancer is. It looks like you're going for a CT scan, for example, and then you direct external beams or rays to target that cancer and zap it specifically. There are actually different kinds of radiation therapy, and I'll talk about that a little bit more in a minute. But it's also important to know that even if you're going to have surgery, you might need something like radiation therapy before or after the surgery, or you might need some of these systemic treatments as well before or after the surgery. Chemotherapy is a kind of treatment that basically goes throughout the whole body via things like the bloodstream, and it kills off any cancer cells that it sees wherever those cancer cells are in the body. And that's why it's called a systemic treatment. So with chemotherapy, for example, if you have a cancer that started out in the breast but has sent seeds to the lungs or the liver, if you give chemotherapy, then ideally the chemotherapy will work to kill off the cancer cells both in the lungs and in the liver and in the breast where the cancer started. Whereas if you have radiation therapy, if you target it at the breast, it will only affect the breast. It will not also target the liver and the lungs automatically. Immunotherapy is a kind of systemic treatment that uses the body's own immune system to fight the cancer. So basically, when you have immunotherapy, it helps the body's natural immune system to identify the cancer a bit better and then to attack the cancer so it's able to kill it off. In a similar way to how our bodies can attack illnesses like coughs, colds, or infections, that's the same way that immunotherapy can attack cancer cells. Hormone therapy is used a lot in cancers such as breast cancer or prostate cancer. And that's where cancers are being driven or grow as a result of the hormones in that area. So in hormone therapy, we block the hormones that are supplying the cancer and kill the cancer off that way. With targeted therapy, you might have proteins, specific proteins that when they become activated, that's what drives the growth of the cancer. Sometimes the growth of the cancer is driven by these proteins that increase the blood supply to the tumor, basically feeding the tumor. And if we give treatments that block those proteins and we block the blood supply or block the food supply to the cancer, then we're killing off those cancer cells. Stem cell therapy is a very important kind of treatment for us to talk about. Stem cell therapy is a treatment that's used mostly in blood cancers. And the way it works is that if you have a cancer in your bloodstream, you can be given very high doses of chemotherapy. And what that does is it kills off all those, the majority of the cells in your bloodstream. And then you can go back and inject new blood cells that will grow and hopefully will not have cancer in them. It is very important because there's another kind of stem cell therapy whereby you're just given a sachet that's called stem cell therapy. And that's not actually where the original term stem cell therapy came from. Those are two very different things. So if you're recommended to have stem cell therapy, number one, it should be done by a specialist in dealing with cancers. And number two, it's important to know the difference between the sachet stem cell therapy, which is basically a combination of vitamins and products like that, as opposed to the stem cell therapy that has been shown by trials and treatments to really help cure cancer. So who are the people that treat cancer? So the people who treat cancers are called oncologists. And you can essentially have, 3 to 4 different types of oncologists. You can have surgical oncologists, radiation oncologists, medical oncologists, and you can also have what I call clinical oncologists. And it depends on where in the world you live as to what kind of specialties there are. So surgical oncologists are quite self-explanatory. They tend to remove the tumors using surgery, and they can also perform biopsies to help you diagnose the cancer in the first place. Radiation oncologists are the oncologists that specialize in giving radiotherapy, like I said. Medical oncologists are the sort of oncology specialists that give systemic treatments. So things like the chemotherapy, immunotherapy, hormone therapies that I discussed. In Nigeria, we have a subgroup called clinical oncologists in Nigeria and in countries like the United Kingdom. Clinical oncologists sort of branch across radiation therapy and medical oncology. They primarily do radiation oncology, but they also have training in giving systemic treatment like medical oncologists. So if you're ever offered treatment for your cancer, it's important to know which kind of an oncologist these specialists are, because just because someone is a surgeon does not always mean that they are qualified to give things like chemotherapy or radiotherapy. And when it comes to giving chemotherapy and systemic treatment, in general, the people who are best qualified to do that are clinical oncologists and medical oncologists. So just to give a little bit more detail about the difference between chemotherapy and radiation therapy. So chemotherapy, like I said, goes throughout the whole body system and kills off cells that are dividing very quickly. So that would be tumor cells, both where the cancer started from and also where it might have spread to. In general, chemotherapy can be given either as a tablet orally or through an injection, so an intravenous drip. The aim of chemotherapy is to kill off the cancer cells so that the tumor either shrinks down and becomes smaller in size or dies completely. The chemotherapy drugs can be given in combination, so you can have one chemotherapy drug, so you can have one or two chemotherapy drugs given to kill off a particular cancer, or sometimes depending on how strong you are, how fit you are, your doctor might say, I would prefer to give you just one drug instead of 2 or 3 at the same time. Sometimes there are a number of side effects to chemotherapy, which I will go through, but essentially, if you're having chemotherapy, those side effects can be managed. So people worry about things like hair loss with chemotherapy, but actually not all patients will get hair loss. It depends on which chemotherapy you're having. You can have other things like mouth sores, nausea, or fatigue, and I'll talk about those in a bit more detail. The other thing you need to know is chemotherapy is given in cycles. So that means that, for example, depending on which cancer you have, your doctor might say you will need to come back every 3 weeks for your chemotherapy, and that could be one cycle. For a different kind of chemotherapy, you might need to come back every 2 weeks. And generally, you will have to complete a number of cycles. So it's not uncommon for patients to receive chemotherapy over a period of 3 months or 6 months, for example, when they're having treatments. Radiotherapy or radiation oncology, it means that you're giving, like I said, high dose invisible light waves to kill off the cancer cells. And by giving those light waves, the cancer can shrink or disappear or be killed altogether. The cancer that is given that treatment is very localized, like I described before, and generally radiation therapy is given over a period of weeks as opposed to months. You can either get what we call internal radiation, where sometimes they can inject the radiation directly into the tumor and it kills off the tumor that way, or you can get external beam radiation, which is when I said it looks like you're having a scan, but the light waves are directed from the outside. The side effects of radiation can also be things like tiredness, mouth sores, nausea, but it tends to be that the radiation side effects occur wherever it's being directed. So if you have radiation therapy for breast cancer, for example, you have to be aware that the skin over the area where the radiation is being directed might get a bit sore and might feel a bit like it's been mildly burned. But you should, if you're starting to get side effects from either your radiotherapy or your chemotherapy, then you need to speak to the specialist who is giving you that treatment so they can adjust the dosage of the treatment that you're receiving. Okay, so with all these side effects that people worry about, what are the actual benefits of giving chemotherapy in the first place? Why do we do it? Well, there are different reasons why we might give people chemotherapy. You might have what we call neoadjuvant chemotherapy, which is where the chemotherapy is given before the definitive treatment. So for example, if your oncologist or the surgeon is planning to is going to recommend for you to have surgery at some point to remove the tumor altogether, they might want to shrink the tumor in size first to ensure that the tumor is small enough to be taken out safely with the surgery. So if you have quite a large tumor, they might recommend that you have chemotherapy to shrink the tumor down to a smaller size, and then you can have the surgery more safely and you'll have a better outcome and less side effects from having the surgery in the first place. Sometimes after you've had your surgery, you might still be recommended to have chemotherapy or as a means of reducing the chances of the cancer coming back. So even though the cancer has been removed with the surgery, there might be some small cancer cells that we cannot even see with the naked eye that are still there. So we give the chemotherapy after the surgery to kill off any of those cells and make sure that the cancer does not come back. But sometimes some patients, by the time we see them, they're not able to have surgery to remove the tumor altogether. In that case, we can give what is called palliative chemotherapy. Just because it's called palliative chemotherapy does not mean that the person having it is not going to survive more than a few weeks to months. What we really mean by palliative chemotherapy is that the aim of that treatment is to shrink down the tumor or to control it and prevent it from spreading any further. By doing this, we're reducing the symptoms that you might be getting from the cancer. So for example, if you're struggling with a lot of pain from the cancer, if you're given palliative chemotherapy and that cancer shrinks down, then the hope is that the pain will go away. And the tumors do respond to chemotherapy treatment. Very occasionally, you might get what we call a complete response to chemotherapy, which is when the tumor disappears completely after having chemotherapy. That tends to happen more in blood cancers, and it's more rare to see that in other cancers such as breast or colorectal cancer, because for breast tumors like breast and colorectal cancer, you tend to need something more, like a combination of chemotherapy and surgery. You might also get what we call a partial response, which is when the tumor has shrunk, so it's reduced in size by about 30%. You might get stable disease, where the tumor hasn't actually shrunk in size or hasn't disappeared altogether, but at least it hasn't spread to any other parts of the body, and the chemotherapy has worked to keep it under control and keep it inactive. Or unfortunately, sometimes you might get what we call progressive disease, whereby even though you're getting the chemotherapy treatment, the cancer can still grow. But then in that case, you should be followed up and have a scan that shows this, so that we would be able to catch it and change it to a different type of treatment sooner rather than later. So that's why it's important that whilst you're having chemotherapy treatments, the specialist, the oncologist that is looking after you, continues to monitor you, for example, with blood tests whilst you're having your chemotherapy cycles, and also with scans like CT scans at the midpoint of your chemotherapy treatment and at the end of the treatment, as a way of determining whether you're responding to the treatment in the way that we hope for. Now, we all know that people are worried about so many side effects from chemotherapy. People talk about hair loss, sore mouth, feeling weak or tired, losing their appetite, for example. You could get nausea or vomiting, so feeling like you're going to throw up every time you eat. Or you can get a change in how your bowels work. So you might notice that you're stooling a lot, or that you get constipation and you're not stooling at all. But the truth is, if we are careful with how we give this chemotherapy, then we can actually control a lot of these symptoms. And like I said, not all these side effects are compulsory. There are some chemotherapies, for example, that do not cause hair loss at all. But I'm just going to run through some of these side effects a bit more. So neutropenia is when your immune system goes down and you can be more prone to getting infections. And if you do get an infection, there's a risk that your body will struggle to fight the infection as efficiently as it would do normally. What we tend to do is we advise our patients to take their temperature whilst they're having the chemotherapy, particularly if they feel unwell. And we can also give injections to boost your immune system and reduce the risk of you getting the neutropenia. If you struggle with nausea or vomiting, then we always, even before you have the chemotherapy, before you experience the nausea or vomiting, we give our patients anti-sickness medication so that they can take that medication before they have the chemotherapy and after they have the chemotherapy in order to reduce the risk of nausea and vomiting. And we also counsel you on how to manage your meals so that they're not feeling overwhelming, or not contributing to the nausea or vomiting. In terms of diarrhea, again, there's obviously always medication that we can give to control the diarrhea. So it's important that you feed back to your cancer specialist if you are having problems with diarrhea. And you might find that there's some particular foods that you would have that will trigger it. So for example, if you eat a lot of vegetable soup and it normally makes your stool loose, then we would recommend that while you're having the chemotherapy, you avoid eating those kind of foods that are high in fiber and roughage and can cause you to get diarrhea. And we also recommend that our patients increase the amount of fluids that they're taking, so that if you do get diarrhea, then your body is not drying out. You're not getting dehydrated and losing too many essential nutrients when you have the diarrhea. If you have constipation, so if you're struggling to pass stool at all, again, we would still say that you should increase the amount of fluids, the amount of water and fluids that you drink, because that can soften your stool and make it easier for it to pass through. We encourage our patients to actually be mobile, to be walking around. Just because you're having chemotherapy doesn't mean that you should be lying in bed all day unless you feel too tired to be walking around. But by moving around, it increases your bowel and can reduce constipation. And again, we always have medication that we can recommend if this is something you're struggling with. For those kinds of chemotherapy that do cause hair loss or alopecia, then we can let our patients know in advance that this is something that could happen so that they can preemptively go ahead and buy their wigs or their head wraps in order to reduce any form of embarrassment from hair loss. And we can also, the good news is that the hair will grow back. Just because you lose your hair whilst you're having the treatment does not mean that your hair is gone forever. It does grow back after you've completed treatment. Pain is something that people worry about with chemotherapy, but I have to say that in my experience, it is not a common side effect for people to have pain caused by chemotherapy. Most of the time, pain is caused by the cancer, and that's why you experience pain whilst you're having treatment, is because the cancer is causing the pain. But chemotherapy is actually aimed to reduce the pain caused by the cancer. Nonetheless, regardless of what might be causing the pain, if it is something you're struggling with, we do have medication that can help control that. In terms of fatigue or tiredness, people can get tired with the chemotherapy, particularly at the beginning of each cycle. So if you're having a 2-weekly cycle, so that you're having your chemotherapy every two weeks, it's more common to feel tired in the first week of the chemotherapy, but by the second week, your energy levels should start to improve. If anyone that you know is having chemotherapy and feeling so tired that they can't leave the house, they can't get out of bed throughout the duration of each cycle of chemotherapy, generally that means that the chemotherapy might be too strong for them. And whoever is giving them that chemotherapy should educate them to let them know if that happens, so that we can reduce the dose of the chemotherapy and make sure that it's the right dose for that particular patient. And finally, there's a lot of sensitivity around both having cancer, having treatment for cancer. It affects what we think about ourselves. It affects our families. It affects us economically, socially as well. And for these kind of situations, we do encourage our patients to join support groups and to feed back to us and to get support, not just from the doctors, but also from their peers who are having cancer as well. Or you can even ask for psychological support, because this is obviously a huge deal. It has a big impact on your life. So it's important that you are encouraged to verbalize the concerns you have so that we can help you with this. And so that's basically my presentation in a nutshell. If any of you have questions, I believe we have 5 minutes of questions now, and then we'll have a panel at the end. So if there are any people who have questions, I'll hand over to Flora to manage that side of things. It is my pleasure to be.
Thank you. If we have any questions, could we pop them in the chat, please? Or raise your hand. Okay. And could I have Dr. Agua and colleagues to take the questions? All right, Gerald, go ahead. Unmute yourself, please. Gerald, you can go ahead.
Oh, good afternoon. Can you hear me?
Yes, we can. Good afternoon.
Okay. My name is Gerald. I'm a podiatrist in England. Firstly, I'd like to say thank you for the discussion. I think it's a very valid topic, especially as it's an area that a lot of people don't really go into. So thank you very much. My question is around, because I see a lot of patients with foot and ankle pathologies, and as well as ulcerations in the lower limb, some of them going through cancer treatment, or some of them just finishing cancer treatment. Is there any advice as to the best way to manage such patients with an open wound that have, that are undergoing this treatment? Because like you said, the immunosuppression, makes it difficult for the wound to heal. So sometimes we get patients coming in for wound dressing for a very long time. Do you have any advice that can help podiatric management for these patients? Thank you.
Okay, who wants to answer that?
Well, I can take it. Gerald, that is a very specialized part of treatment. And I think maybe your colleague that deals with wound management, we could pass the question to her if she could give some specific advice. because doctors per se are not the best for managing wounds. So either nurses or podiatrists with specialization in wound management are these people to answer the question. I wonder if my other colleagues have anything to say.
Mr. Ojutikwu, any comments on that?
As a gynecologist, is way outside my area of expertise. So unfortunately, no, I haven't. No.
Okay, no problem. So Gerald, are you okay with that to contact?
We'll pass the question and revert. Yeah.
All right. Okay, so Kayode, you've got your hand up.
Yes, thank you so much for this very informative program. So my question is, I see more of the treatment. Is this cancer preventable? What can people do to ensure that, yes, you don't have it, rather than we looking at the treatment? Just a question.
Okay.
So, sorry, could you? I didn't hear that. Was that?
All right, Kayode, do you want to repeat your question again, please? If you unmute yourself.
Okay, my question is this preventable? Like, for instance, maybe a parent already have cancer. So how can you prevent it, maybe your generation, if you notice that your family has cancer? Is this something that, is there anything to do to prevent it, rather than we looking at treatment?
Okay, I could, let me take a shot at this. Code, it's first of all, cancer is not one disease. Yeah. As Chinya, as the oncologist, Dr. Wuja, has she explained, the principles are the same, meaning that you have cells that don't die, and because they don't die as they should do, they become abnormal, but it's not one disease. And the factors that initiate it could vary considerably depending on what part of the body is infected, just to say, or affected, sorry. The same way as we know that there's an association with lung cancer and smoking, we also know that there are associations between skin cancer and the sun. So the factors that affect it are quite different. There are also, apart from what we call factors that we get involved in or that we come across in day-to-day living, smoking, sun, drinking, alcohol, and stuff like that. There are also genetic factors which make us individually susceptible to it. And how much genetics and how much environmental factors play in development of cancer also varies according to each cancer. So from that point of view, some cancers you will get anyway, because you have the genetics and the genetic loading to say that you will get it. And the best you can do is probably preempt it and get it treated beforehand, or delay the onset by certain measures. But some cancers are purely related to more, not purely, but almost, completely related to the environment. And for many, lung cancers might be one of them. And so if one avoids smoking and other atmospheres, secondary smoke, you might be able to avoid getting that just through those measures. I mean, that is rather simplistic, but that's it. So never think of cancer as one disease. And when I see these comments, sometimes from politicians and sometimes in some things that we see on the media, when they say, we're going to we're going to eliminate cancer. It doesn't really make much sense, because cancer is a wide range of things. Does that help?
Thank you for that. He's muted now. Just let us know in the chat, Kayode, if that helps. I think Mr. Akpakama wants to contribute.
I think Dr. Jukutu has said most of what I wanted to say. Cancer is not a disease that's where there's a cause and effect. There is some associations. So if there's no associated with a particular cancer, you can avoid those etiological factors. For instance, don't smoke, don't work with asbestos. If you are don't go out in the sun and go and sunbathe, things like that. When there's no clear-cut link between one thing and the cancer. The most important thing is if you are at a higher risk of any cancer for any reason, start screening yourself early so you can achieve an early diagnosis and early intervention.
All right, thank you. Kaide says yes, thank you. That was very helpful. All right, Gregory, unmute yourself, please. Gregory? All right, we'll move to Tunji. If you can unmute yourself, please.
Thank you very much. Can you hear me?
Yes.
Okay. Let me thank you for bringing this to us, and I want to thank the presenters and the experts around us. Please, can I find out, is prostate cancer permanently curable?
Okay.
Yes, please. Thank
We're
you.
going to address that later. Our third speaker will be addressing prostate cancer, okay?
Okay. Thank you.
Hold on to your question till then. Okay. All right. Okay. All right. Let's move on to the next speaker. Our next speaker today is Mr. Ojitiku. He's a consultant obstetrician and gynecologist with over 32 years experience in the specialty. Sorry, I'm getting feedback. I don't know if someone, okay. So he has over 32 years experience in the specialty. He was appointed to his substantive consultant post 20 years ago. He has had additional roles as a clinical director, clinical governance lead, undergraduate tutor, and course organizer to a number of training courses. He's been involved in teaching medical students, physician associates, midwives, nurses, trainees, and general practitioners. He's also provided information and lectures to patient groups. He runs a busy private practice in Essex. He has a number of personal publications and has been the principal investigator in a number of important international and national multi-center investigations. He has a specific interest in managing heavy menstrual bleeding, pelvic organ prolapse, menopause, and post-reproductive women's health, in addition to pelvic pain. So over to you, Mr. Ojitiku. I hand over to you now. I'll just enable sharing for you. Just give me 1 second. Okay, you should be able to share now.
I think that's the one.
Yeah, it's loading.
Okay.
You might have to do what we did earlier and stop and do it again.
Right, okay. Yeah.
Okay, while we're waiting for the presentation to come up, just let us know in the chat where you're joining from. And remember, if you have any questions, just put them in the chat and just prefix it with a Q so we can identify your question easily. Okay? All right. Yeah, we can see it now.
Okay. Right. Okay. Thank you, Andrew, Flora, John, and all the members of the Gintavenes team for asking me to give this talk. Now, it is about cervical cancer, and cervical cancer is a quite a wide topic, and I could probably end up talking all day about all aspects of care. But what I've decided to concentrate on is first just understanding what it is, and probably what's most important as a health promotion for health promotion is how we're going to, if one can understand it, then we can understand how to prevent it. That question I had earlier on is very pertinent. I hear it quite a lot. or how can we prevent cancer, or how can we stop it? Now, fortunately, cervical cancer is a preventable cancer, and it's one that we've known about for many, many years, and we understand the biology of cervical cancer, and that's helped us be able to understand how to address it and deal with it. Now, this is what we're talking about. This is a cervix. Now there is a small tumor there, and I want us to ignore that because it's not a great picture, so one can't see it very well. But this is what the normal cervix looks like. Some people refer to it as the neck of the womb. Okay, and if you look in our schematic diagram, this is the area we're looking at here, and this is the top of the vagina. Then you've got the cervix, and the cervix is actually the neck, so it's the neck of the womb, and this is the rest of the womb. The body of it with the tubes, and in addition to that, you've got the tubes and you've got the ovary. Now, why is the cervix such a? Because we can get tumors from the ovary, tumors from the body, and tumors from the cervix. And you might wonder, why are tumors from the neck separate from the body? And that's because the biology of the body and the neck, they're a little bit different. The neck just here, you've got really, really delicate cells. And these delicate cells, they shed and they change all the time. And whilst they go through that process of shedding and changing quite frequently, that's when external factors can cause them to become abnormal, so that they stop dying off and they stop growing the way they're meant to grow. And this is where, when we do our screening and cervical sampling, we take the sample from here, and it's those cells that can become abnormal from which we take our samples. And that's a really important concept to try and understand here, that this area is so important. And it's here, it's the area just here. So you get these little delicate cells around here, which are very, very different. And you see the reasoning for the abnormalities here are very different from the reasoning for abnormalities in the body of the uterus. So the cervix is quite different. Now, gynecological, let me just move this out of the way if I can. Oh, I can't. Okay, can I close this? Okay, it doesn't matter. So there are over about, you see the whole screen, or is there something can you see the bar on the way here?
No, it's fine. When you're talking, it's not.
You can see it, okay. So there are over 20,000 gynecological cancers in the UK every year. And during this talk, I'll talk about the UK and a bit about the world too. And maybe I'll mention something about Nigeria. But I'm just trying to give us some idea of the scope of this problem. But suffice to say that we don't only have cervical cancers in gynecology. We have endometrial, we have ovarian and endometrial. So endometrial is the body of the uterus. Ovarian, I pointed out where the ovaries are. And you also have vulval, which is on the outside of where the lips of the vagina are on the outside, and vaginal. Now, these last few they're not common. Most gynecological cancers that we come across in regular practice now would be ovarian and uterine, and followed by cervical. And the reason why cervical is down to third out of our gynecological cancers here is that it's because of the effects of screening, what we've had here. And I can say that over the period of time that I've been working, I remember when I was a registrar and an SHO, I used to work in a team where we operated on one cervical cancer every week. And these days, it's a little bit of a rarity for me to, if I see one in 2 or 3 years, well, I might be lucky or unlucky, depending on how you want to look at it. But it is still the fourth most common cancer globally, okay? And 90% of the deaths due to cervical cancer are in low to middle income countries. Okay, and if you can see on this map, the green represents areas where you have very low incidence and deaths due to cervical cancer, and the reds and the blacks are where you have very high incidence. And you can see the burden of it is mostly in Africa, a little bit in South America too. But and the difference, the reason why you have these differences is because all those countries that are green and sort of like, yeah, they have, first of all, they have healthcare service, national or not national, but they have a healthcare service, okay, and they also have screening and other attributes to healthcare, as opposed to what you tend to get in Africa, where it tends to be a free for all. Now, the Nigerian Institute of Medical Research estimates that you have about that 28 women every day died from cervical cancer, and then you get over 10,500 deaths due to cervical cancer in 2019. Your life risk will be about almost 2% in Nigeria. And as I said, we haven't got a national screening program, and they've advocated that we need to have better awareness, and prevention and access to treatment is really, really important. As I said, we have no data on this disease. We don't have any on vaccination. We don't have any guidelines on how to strengthen our early detection of the disease, because we haven't got a health service. There are no clearly defined referral systems. And despite that, I have to say that the average we in the world is about 13.3 per 100,000 cases, and we're about 11.9. So we're not the worst by any means, but it's still far from where we should be, where, you know, less than 4 per 100,000 cases is where we need to get to in order to say we've actually got the disease under control. Now, in Nigeria, only 11% of eligible women have been screened within the last 5 years, and only 14% have ever been screened. Okay, we have a dearth of, you've just had a presentation from an oncologist. In Nigeria, we have 1 radiotherapy unit per 100,000 cancer patients. We have very few radiation oncologists. We have about 6, when we should be talking about at least about anything from 250 to 300 per 10,000 cancer patients. We have a significant burden of HIV, which is a risk factor for developing cervical cancer. And as you said, we've got no nuclear medicine physicists or medical physicists, and these are people that we need to deliver high quality treatment, and we have hardly any of that in Nigeria. Now, I always like to go into a little bit of history, because I think it's very helpful to give us a background so that we can understand things. And as I said, it's an old disease, you know, noted by Hippocrates, 400 BC. But in 1925, then we started to see, have a bit better of understanding of things. We had a colposcope, and a colposcope, essentially, colpus is vagina, scope is to look. And essentially, it's a microscope just to look at the vagina or look at the cervix, actually. And that gave us a little bit more, we started to develop a little bit more understanding as to what happens in the cervix. 3 years later, Papa Nicolau developed a technique of testing cells on the neck of the womb. That area that I spoke about, of delicate cells on the neck of the womb, is where we take our smear tests, and this is developed by Papa Nicolau. Then they developed the screening test in 1941, and in 1960 cervical screening began here in the UK. Now, what's interesting here, in 1976 we first of all identified HPV, which is human papillomavirus DNA, in cervical cancer and in genital warts. So that sort of helped us to understand that considerably. Now, and of course, one of the reasons why we started to look at that was because we realized that there has been for many, many years epidemiological evidence, and epidemiology meaning that I don't know, studying the people's behavior and what tends to happen in the world. So there's been evidence that this cervical cancer may be a sexually transmitted disease. And one that we know it was more common amongst female sex workers. It's rare in nuns, except for those that have been sexually active before entering the convent. And it's more common in second wives of men whose first wives died of cervical cancers. And it's rare in Jewish women. Now, I mentioned smegma, and those who are here, who are the doctors, might remember this from medical school. There was a time before we realized fully that whether this was related to HPV, was that there was a feeling that smegma is these are the debris and dead cells underneath the foreskin in those that are uncircumcised. And there was a feeling then that might be the reason that the substance in smegma, these dead cells, might account for the sexual transmission. But that's I think that's been blown into the water now. That's the colposcope, and as I said, it's just a refined microscope to look into the vagina and have a look at the cervix. These days, you might, rather than looking down eyepieces, we'll have a screen which help us to look at things. Going on with the history, in 1988 we had the national, and this is here in the UK. We had the screening program which was started, and what was important about that was that they had a system called computerized call and recall. And essentially what that was that once you had once you were called, you had your data was on the computer, you were called for your test, and if you had your test, you were recalled if you needed to have it repeated, or recalled if you needed to have the next scheduled test. And so it kept track of people, and that computerized system made the whole process more robust. The target for the program was to ensure that we screen at least 80% of the eligible population, and it was the program has been a great success. In 2004, we introduced liquid-based cytology, and what cytology is, it's those cells that we take from the lining from the neck of the womb. We put them under the microscope and we actually have a look at them, and that's how we help us to make a diagnosis. And one looks for abnormal cells in those. Now, part of the problem with the old screening program is when they take those cells, they put them on a slide, and you look under the slide in the microscope. The problem is sometimes there was blood on it, sometimes there was mucus and other things that made the cells a little bit difficult to read. So you could have a smear taken, and after having a smear taken, they'll call you back and say it's inadequate, that you need to have another one. And most GPs here will remember this. It was quite common back before we had liquid-based cytology. And it's, even having a smear itself is not the nicest of things, but then having been called back to have another test again. And of course, when you're called back, for a lot of patients, they're very anxious and they feel that, well, is there something wrong? And no, it's just that the technique can be a little bit flawed. But liquid-based cytology reduced that considerably. So the court having to be recalled back is now almost a thing of the past. And then of course another game changer in 2008, where they introduced the national vaccination program. And in 2012, after further understanding of the role HPV took in the development of disease, they developed what we call a HPV triage, where effectively, before you take a smear, but they test the smear cells, those cells, for HPV. And if it's HPV negative, that's it. You don't need to have any, they don't need to read the cells or do anything anymore. If it's HPV positive, then they go on to look at the cells under the microscope. And of course, because that was so successful, they decided in 2019 that HPV triaging replaced cytology because it was a much more accurate way of looking at things. Now, just a word about screening. So what we do for screening is essentially you're trying to identify early disease or people at increased risk of developing disease in healthy people. And of course, when considering that, there must be benefits from screening. It mustn't cause harms, including psychological harms, and it needs to be a bit cost effective. And and that's where all these screening programs come from. And actually, this cervical cancer screening program is one of the most cost effective programs there is out there. And it has been shown to be successful in reducing cancer, and of course, possibly eliminating cancer worldwide, if one can ensure that we can have these screening programs available. Now, this is what some of you might have been familiar with. This is a little pot. There's fluid inside it. You've got the little sampler which they put in the cervix, and then you suspend it you sort of shake it in that pot. One way of checking to see if you've got a half decent sample is you hold the pot up to the light, and you can see the cells inside it. That can tell you that you've probably taken an adequate sample. And those cells, this is what they look like under the microscope. Now, these has been stained, and these are all, the blue ones are all normal cells, and these red ones with big, they call these nuclei. These are the hearts of the cells with all the DNA inside it. These are the abnormal ones. Yeah. So you can see that doing this can be so much more objective. So liquid-based cytology, as I said, it has improved diagnostic accuracy, reduction in unsatisfactory or inadequate smears, and the samples can be taken even if bleeding. I mean, just a little bit of bleeding is okay. Heavy bleeding might be a bit problematic. So even if there's a bit of bleeding, the samples can still be taken. And of course, the other thing is that that screening of them, you don't need to be eyeballed by the person in the lab. They can put it do automated screening with a computer, and that can tell you whether there are abnormalities in it. And it makes it much more objective, much more effective. Now, if there are abnormalities, they tend to be graded mild, moderate, or severe. And if there are persistent abnormalities, need to be referred for a colposcopy. And then the colposcopy is looking at using that microscope to have a look directly at the neck of the womb to try and find out whether there are visual abnormalities there with the microscope. Okay, and if there are abnormalities, then they take a little biopsy. And we have to remember that even if those abnormalities are present, the disease we're talking about takes about 15 to 20 years to develop. So it is not, it's a long, the lead up to the disease is quite long. And that's why screening for it is so successful. You got ample time to get in there and make a difference before the disease develops into a frank cancer. And this is, I'm sorry about the quality of this slide, but you can see once you've got a HPV infection, 80% of those infections are transient, they go away on their own. And 20% of them are persistent. And if they're persistent, they can progress from low to high grade lesions and even to cervical cancer. But you can see the lead phase is of the order of about 15 years. But interestingly, some of these arrows go back and forth. So even after you get low grade abnormalities, they can go back again. And even high grade abnormalities can go back again, but less likely than low grade abnormalities. Okay, so the point I'm trying to emphasize here is that having abnormalities doesn't mean that one is doomed. Most of them are cleared themselves. And even once you have persistent abnormalities, there's still a chance that they can go on their own. But obviously, the higher the grade of abnormality, the less likely they are to go back to normal again. HPV or papillomavirus is also seen not just in cervical cancers. You can see it in anal cancers, vulval and vaginal cancers, penile cancers, and oropharyngeal cancers. And this all plays into the sexually transmitted nature of this disease. Okay. Now, there are a number of different serotypes for HPV. But we know that especially types 18 and 16, serotypes is there are HPV is not one virus. It is one virus, but I mean there are different types of that within that virus, and in actual fact, they're probably up to about 80 or so different types of them. Most of them are completely benign, but we know that there are some types that are specifically prone to develop into cancers, and types 16 and 18 are the most common. They also have others like 31 and 33 and 45. And when they do the testing, they test for high risk HPV and low risk HPV. But we know that high grade lesions taken from the neck, from samples on the neck of the womb, are accounted for 50% of them are caused by 16 and 18. And as I said, the presence of chronic infection can lead to precancerous lesions. Abnormal changes are actually more often seen in younger women. Abnormal cell changes are often more seen in younger women, but then again, they're more likely to regress and resolve on their own without doing anything. So the importance here is that one shouldn't panic if there are abnormalities. Many of them get back to normal on their own. And in actual fact, before we used to do quite a lot of we used to offer treatments for these, and we've realized that we've been over-treating. So in actual fact, sometimes just observation will avoid unnecessary interventions. And in essence, HPV, or the human papillomavirus, is what we call an oncogen. An oncogen is a cancer-causing agent, okay? And as I said, it's transmitted through sexual intercourse. Now, most infections happen shortly after the onset of sexual intercourse, okay? However, as I said, most of it is transient. And I talked about HPV 16 and 18. If you look at the cancers as opposed to the high-grade lesions, they account for up to 70% of those cancers. Now, just a word about immunocompromising individuals, and mostly we're talking about those with HIV. They make up to about 5% of those with cervical cancers. They are 6 times more likely to develop cancers in immunocompromised women, particularly HIV. And we have a HIV problem in Nigeria and in Africa as a whole. And of course, the lag phase is a bit shorter, 5 to 10 years, when compared to those that aren't immunocompromised. So for the GPs, if you pick up an early cervical cancer, especially, well, anywhere actually, but I would say especially here in the UK, one has to think about the possibility that do we consider that there might be some sort of immunocompromise in this person, for which we need to review. Okay, and also in this group of patients too, they have a greater risk of treatment failures and a recurrence of disease. Now, this slide, I put it here, but I think we take it with a healthy pinch of salt, okay? And this is because our medical school teaching often told us that, well, postcoital bleeding or bleeding after intercourse, one needs to think of a cervical cancer, okay? And yes, that's possible, but there are lots of other benign causes for postcoital bleeding, including a benign ectropion, which is more likely to be the case. Also for postcoital bleeding in women who are sort of postmenopausal, it might be because they've got a condition called atrophic vaginitis or dryness due to a lack of estrogen, and you can get them here in the vaginal bleeding in the postmenopause. Bleeding between periods can happen between premenstrual spotting, postmenstrual spotting, more often than not seen with polyps, and that can be in the lining of the womb, and they can be self-limiting. So the point I'm trying to make is, though we have these symptoms here, I'm very cautious in actually talking about them, and I must admit that these symptoms, their relevance is more important in those that haven't been screened. For women who've been screened regularly, one might argue that these symptoms might not be particularly helpful. And that's why I've said that, you know, that they're commonly seen in other benign conditions. And because they're commonly seen in other benign conditions, they're of not great diagnostic value because they have what we call a high false positive. False positive results, meaning that telling you there might be a disease when in actual fact there isn't. Okay. For the GPs in the house, I always say that the most important aspect, which I think seems to be dying these days, and I think because of changes in how we view our healthcare, but is to do a speculum examination, an examination to examine and look at, eyeball the neck of the womb or the cervix. Yeah, because you'll be able to see in the countries where there's a lot of screening, like here, you'll be able to give some reassurance that the cervix looks entirely normal. And in countries where there isn't any screening, you do a speculum examination. I guarantee you will not miss a cervical cancer. It will hit you right in the eye. You'll know that that's a big problem. And in this country, you'll be amazed to know the number of times that I see have people referred for postcoital bleeding or other causes, and they haven't had a speculum examination at all. Okay, so, and the other thing I might mention too is that if the cervix looks abnormal, referring in for colposcopy is a waste of time. They need to have a biopsy, and that's why they need to be sent through to any gynecologist, and you know they can take a biopsy from the abnormality and to get a diagnosis of it. Now, just a few words here because of this and what we're talking about and the role of HPV in it. We have the World Health Assembly, a part of the World Health Organization, has a global strategy to eliminate cancer. And eliminating cancer, cervical cancer, is having less than 4 cases per 100,000. Okay, and as I said, currently about worldwide about 13.3. Bearing in mind that in most Western countries, it is very low, sort of less than 4 cases. But in some countries, they're up to 15, 20. And they have 90, 70, 90. They like all these jazzy new acronyms by 2030. And what they're aiming for is 90% of girls vaccinated by the age of 15, 70% of women screened with high performance tests at 35 and 45 years of age. This is worldwide, bearing in mind. And what they mean high performance test, this is not just looking at the neck, the cervix, this is doing something like liquid-based cytology. And 90% of women identified and treated. Okay, and the strategies are primary, secondary, and tertiary. You must remember that the greatest impacts on world health are clean water and vaccination. Okay, and we know that what the World Health Organization has recommended vaccination for 19 to 11-year-olds, and also for boys too. And in this country, we have quite a huge coverage of it. One of the advantages of vaccination too is that also you might have heard with the recent COVID that they're talking about herd immunity. So once you get quite a lot of people vaccinated, the actual virus that's in the environment tends to die off because there's a great deal of immunity in the community. In this country, we tend to screen from 25 to 64 years of age, 3 yearly from 25 to 49, and then every 5 yearly from 50 to 64. We screen first of all for HPV, and if that's negative, we have routine recall. And if it's positive, they take the same sample and they have a look at the cells for abnormal cells. If the cells are abnormal, then they go on to look for colposcopy. And as I said, this triage, HPV triage, makes it much more cost effective. This is what WHO recommends. 9 to 11, 9 to 14 years for vaccination. They also emphasize sex education, which was age and culturally appropriate, condom promotion, and male circumcision. And along with health warnings about smoking, which the cyanides and other noxious substances in cigarettes make those delicate cells in the neck of the womb more prone to infection with HPV. And secondary, and this is for the World Health Organization, as I said, screening from the age of 30 every 5 to 10 years, and having good quality and palliative treatment. Okay. Now, one thing that I think is really important, and this is just here for the UK for the time being, is that although we've seen a significant reduction in cervical cancer mortality, and as I mentioned earlier on, I've seen the difference as in the numbers that come through the doors, but we have had and because we've covered a lot of teenagers with vaccination, and the crude mortality rate in this country is quite low. It was 3 per 100,000 in 2014. And because we had achieved that target of 80% of the eligible population being screened in 2007, but since 2007, we've seen coverage fall. And there are a number of reasons why. We've noticed a failure to attend for screening, cultural barriers, language barriers, a lack of female sample takers, and poor understanding of the role of HPV in the risk and in the development of this disease. And you can, if you have a look at this infographic here, you can see where the red areas are the areas where we're not doing great as far as early diagnosis is concerned. And you can see even down here in the southeast, some of these areas here, that's Thanet, that's I think that's sort of Grays area, no, Dartford area or thereabouts, and Southend and East London. So we're sort of we're sort of missing a few, or we're not doing as well as we should be doing, if I could put it that way. Sorry. And there are some reasons why. And when we've looked into things, we've found that screening in there's been a significant drop in screening for the over 50s. And when it's at a 17-year all-time low, and when we've looked at that, we know that for this women, almost 30% of them find smear taking very uncomfortable, and this is most likely to be due to the fact that they're estrogen deficient, and maybe, you know, consider, I can always get away, most times I can get away with using a smaller speculum, okay, and sometimes I give them some treatment with some local estrogen for a couple of months before trying to take the smear, and that will make it a lot easier. But one needs to be aware of that. With the younger age group, they tend to be a bit worried about whether it would be painful and embarrassing. So they're a bit and so they need some encouragement from that point of view. Sometimes they're a bit concerned that it might pick up STDs, or concerned that it might pick up a cancer. These are the reasons, you know, on surveys that tell us why they're not attending. And of course, some of them believe that because they've been vaccinated, they don't need to have a cervical smear, but they still do. So that's incorrect. Yeah. With Black and ethnic minorities, we also know that there's a poor understanding of what cervical screening is all about. A greater proportion of them have never attended for smears when compared to white women. They also find that they're more uncomfortable about being examined or having a smear taken by a male GP compared to white women. And some actually wrongly feel that it's cervical cancer is not a disease that affects their communities compared to others. And deprivation is also important. There's low screening attendance is associated with increased risk of cervical cancers. There are higher rates with smokers, higher rates with those that have early age of first coitus, and higher incidence with those with multiple sexual partners. We're on the last few slides now. So women with learning difficulties are less likely to attend smears, but they still need to. Lesbians and bisexuals are also less likely to participate in the program. and they wrongly believe that cervical cancer doesn't affect them because they don't have intercourse with men, but it's related not to it's any sexual activity that can transmit HPV, and we can see oral sex can do so. We can see oral pharyngeal and other causes for it. And also in transgender, female patients will be invited for smear test because the screen only registers and identifies females, but trans men will be seen on the list as female, and they'll be invited for the test unless, of course, they've had a hysterectomy. But trans women will not be invited for the test. And maybe a more appropriate term that should be on the register is people or persons with a cervix. Non-binary is not recognized. So the final thing I'd like to mention here is that there has been a trial of self-sampling, which is, as far as I'm aware, is yet to be published. But they've done it in East London in areas where screening attendance is quite low: Barnet, Camden, Islington, Newham and Tower Hamlets. And it ended at the end of 2021. Now, essentially, they were looking for women who were 15 months overdue. And what they did is that they gave them self-testing kits where they could put the swab inside and take the sample in order for it to do the test. And it's found to be very effective. And what they noticed is that those women who participated in those tests, when they did a survey, they were more who had either delayed, missed, or never attended for a screening were more likely to do so if they had a self testing kit. So, look at this space. This could be a game changer. So, in summary, health education is important, and that's why we're here today. Vaccination, high quality screening, and identification of disease, and access to high quality treatment. And that's it. Thank you for listening to this.
Thank you so much. That was very informative. You have quite a few questions in the chat. So the first one is, can HPV test be done for men and boys?
A good question. Very good question. Technically, can it be done? Yes, it can. Is it available? I don't know. It's not within the screening program, I have to say. Not within the screening program yet. But I know that some private facilities, they shall I stop?
Yes, please. Yeah.
Some private facilities, they do offer. Hold on a second. Some private facilities offer screening tests, which one may want to use. Okay, but not national. It's not part of the national program.
All right. Okay. And the same person is asking, what is the contribution of HPV to cervical cancer? I know you touched on that.
Yeah, as I said, that the high risk HPV, they find them in 70% of cervical cancers. So when they take those tissues and they take them to the lab and they test them, they find high risk HPV 16 and 18 in 70% of those. By the time you add 30, 31, 33, and 30 and 45, you might be getting closer to 90%. Okay. And also other cancers too: penile cancer, anal cancer, oropharyngeal cancer, and others.
All right, Coyote, I hope that answers your questions. The next question is, if a woman who's had a total hysterectomy, is there any point in testing for HPV since the cervix has been excised?
No, she hasn't.
Rather.
Yeah, she hasn't. Now, you can get it in the vagina too, but those are relatively rare. And we don't actually have a screening test for those, because this test, cervical cancer screening, just tests for cervical cancer. We don't have screening tests for vagina, vulva, anal, oropharyngeal, or penile. But then again, as I said, those are still relatively rare.
All right. Okay. Next question is, does washing your vagina with soap increase the risk of cervical cancer?
No, it doesn't. But washing it with soap is not a good idea. Bad idea. Yeah. because what that does is that what you do is that there are bugs in the vagina. We call it normal vaginal flora. Just like we have bugs in our skin, we have bugs in our throat, and those bugs look after us. Okay, so we live together. Scientists call it we live symbiotically. They look after us, we look after them. So if you wash those good bugs out of the way, you allow bad bugs to get in there. And once the bad bugs get inside, then you start having lots of problems. So washing the vagina with soap is not a good idea.
Thank you. Yes, ladies, please, washing the vagina with soap is not a good idea. And please pass that information to friends and colleagues. Okay, next question. What is the current schedule for HPV 1, 2, and 3 shots? What's the schedule? How many injections do you get? How many vaccinations? Is it 3, 2?
It's 3, and I really can't remember. I haven't looked because when I was involved in the program, it was quite a while ago, and when they just introduced it. There are a number out there. Gardasil, they've got Gardasil, they've got Cervix, and I think Gardasil is what we prefer now in the UK. Because that also covers genital warts, but it's 3 shots. But you see, even when you're taking, just like all the, you get 1 shot, you get, I don't know, maybe 50% immunity. By the time you get up to the 3rd shot, you're getting up to about 80-90% immunity. So yes, one must complete all the shots. But I'm not sure about but they sometimes adjust things a little bit according to local the local resources available.
All right, okay. And when you were talking about vaccination, someone was asking that you didn't talk about the vaccination for boys. Are boys to be vaccinated as well?
Yes, I did mention it. I just sort of I sort of glazed over it. But boys, from 2019, they started vaccinating boys, and the whole idea being is that because it helps with the herd immunity. Okay, it also because of the fact that nowadays we don't have clearly defined whether it's male and female relationships, female, male. Some are bisexual and they tend to have both male and female partners. So it really doesn't make sense not to vaccinate boys. But when the program started, it didn't start with boys. Australia started vaccinating boys before us, but since 2019, we've offered vaccine to boys.
Okay. Thank you. Last question, and there's quite a few questions about how the vagina should be cleaned. Please, could you just touch on that, if it should be?
Just water, just plain water. That's it. No douching can alter the flora. Plain water, and what that does, it just gets rid of. You have to remember the discharge from the vagina is a reflection. There's a normal discharge which is there, and it's hormone dependent. What it is, and that discharge is the fact that sometimes it can be a lot more copious, meaning that there's a lot more of it, and that depends on progesterone content and estrogen content. It tends to be a lot more copious around the time of ovulation, and at the time shortly after, before the period, it's less so. Okay, but that is quite normal. Now, when you put soap and other agents inside the vagina, they alter the pH. And if you alter the pH of the vagina, you're making it susceptible to problems. It needs to be slightly acidic, okay? And bugs thrive in an alkaline pH. So once you do that, you're giving bugs an opportunity to get into it. So normally it should just be water, and that's just it.
I think the issue is sometimes people confuse when they say the vagina with the vulval area, because somebody's asking, can you?
So the vagina is inside. Yeah. The vulva on the outside, you can use soap on that. That's fine. That's absolutely fine. Okay. But inside the vagina is no, that we shouldn't do that.
All right. Thank you for that. Okay. So Vivian is asking, in order to eliminate cervical cancer, which is a laudable goal, is early detection by screening critical?
As you can see from my summary, if we want to get to that magic less than 4 per 100,000 all over the world, as they've achieved, we need to have 3 things. We need to have 3 things. One is early prevention, which is vaccination. So we need to vaccinate our teenage girls before they start, and boys before they start to become sexually active. Okay. 2, we need to have a good, so we need to have a secondary prevention. That's a good screening program. Okay. So we screen. Once there is an abnormality, we treat, we manage, and we treat appropriately. And also, once we have a cancer, if one breaks through, we detect it really early, we treat, and even with early treatment of early cancers, one can affect a cure. So all those 3 elements are what are important. Emphasize again: vaccination, screening, early detection.
Fantastic. Thank you. And on that note, we will move on to our next speaker. Thank you so much, Mr. Ojitiku. We'll still have questions at the end. If you still have more questions, we'll still have a panel at the end. But because of time, we'll just move on to the next speaker. Thank you very much. So our next speaker is Mr. Apakama, and he is a retired urologist, and he'll be talking to us about the prostate and prostate cancer. Over to you. Just need to unmute. There we go. You should be able to share.
Yeah. Can you see it?
Not yet.
No, Joy.
Nope, not yet.
Exit and try again.
Mm-hmm. While we're waiting, if you had questions for the previous speakers, just pop them in the chat so you don't forget when we have the panel later on.
Can you see it now?
No.
Not yet. It did work earlier on.
Yeah.
And I have made you co-host, so you should be able to share.
I'm sharing, but it's not somehow you're not seeing. I'm not sure what's going on.
All right, let's just stop again and then retry and try again. Okay, what we'll do is while you're trying to do that, we'll just get John to quickly say a few words, and then we'll come back to you, Mr. Apakama. So hopefully by then it should be working. Is that okay?
Let's hope so.
All right. Go over to you, John.
Okay. Let me share my screen. Can everyone hear me?
Mm-hmm.
Okay. So sharing the screen now. Okay, so good evening. We're delighted that you've been able to join us from wherever it is you're calling from. Those of us here in Nigeria, some people in the UK, some people in the US, and then some people, of course, in Canada and the rest of the world. So we're delighted to have you this evening on this webinar, and we're glad that you've been able to stay to this point. We want to just say a few words and give a vote of thanks. First of all, we want to thank the speakers who have done a very fantastic job with their presentations. I think they've been very captivating and easy to follow. As usual, their presentations are excellent. So I would like to say a very big thank you to the facilitators, not just those of us that have spoken today or the people that have spoken today, but those that spoke last month, rather, the first part of the series. Okay. Can you still see my screen?
Yes.
Hello. Okay, hang on. Let me try that again. I'm sorry. I think I clicked on the wrong thing. Okay. So where was I? I think I stopped where, okay, yes. So I was thanking you for joining us from wherever you're calling in from. We're glad that you've been able to take out the time to avail yourself of this critical information that has the potential to save not just our lives, but the lives of our loved ones and friends and people in our wider circle as well. Now, there's a possibility that you can get, you might need a participation certificate for this webinar. And if that is so, all you have to do is send us an email and ask for one, and then we'll send you a virtual copy. So I placed the email in the chat. I placed the email in the chat, and I'll do that again after speaking so that we can be able to do this. Also, as touching follow-up questions, the questions that we're not able to take here on the panel, and because for whatever reason, anyway, because of time and availability of the specialists, you can just send them by email, and then we'll do everything we can to address them and then send you replies by return emails. Okay, so today, as usual, this session is being recorded and uploaded to our website, uploaded to our YouTube channel, which you can visit, and you can, of course, this is going to be uploaded by later this evening. But then you don't just have the benefits of watching back what we're doing here today. You also have the benefits of being able to watch back what we did last month and previous meetings as well on our catalog of content. So please help us grow the channel by liking, subscribing, and also spreading the word by sharing the videos and sharing the videos to your wider circle, so that the channel grows and the impact as well is more palpable and more amplified. So in the event that you're willing to make a donation to Gintavenes Health Foundation, we enjoin you to use our Stanbic IBTC account. The account details are here on the screen. Stanbic IBTC, account number 0028901410. So that's again Stanbic IBTC, Gintavenes Health Foundation, account number 0028901410. Then you can also visit our website, which is up and running now at www.gintaveneshealthfoundation.org. So Gintavenes Health Foundation is one word, .org. So there you can get to know us a little better and then see how you can get involved and keep track of what we've done in the past, what we're doing now, and what we plan to do in the future. So thank you again for joining. Enjoy the rest of your evening, enjoy the rest of the session, and stay safe, everyone. Thank you.
All right, thanks, John. So we're going
Laura.
we're going to our next speaker now. Mr. Pakama, we're going to try again. You should be able to share. I've made you co-host. So let's see. Yes. Here we go.
Can you see now?
Oh yeah, it's come up.
Yes.
Is it working?
Yes.
Yes, it is.
Okay, thank you. Sorry for the technical glitch. Don't know what happened. And thank you for the opportunity to try and give this talk about prostate cancer. Hopefully by the end, there'll be a bit more knowledge about prostate cancer. The prostate gland and the seminal vesicles are part of the male reproductive system. The prostate gland sits below the bladder and in front of the rectum. It surrounds the urethra, which is the tube through which the men pee. And the cancer, basically, like was said before by the oncologist, is the result of abnormal growth of cells, which takes over the body's normal cell function, making it harder for the body to work the way it should. I've got a bit of old statistics. The statistics here is from 2015 to 2017. There's about just about 50,000 new cases in the United Kingdom every year of prostate cancer, and that accounts for 13% of all the cancers in the UK. In general, in the Western world, prostate cancer is the most common cancer in everybody and the most common cancer in men. It accounts for about 26% of all new cancers in men in the UK. And if you look at prostate cancer incidences historically, there seems to be an increase in the from the 1990s, the rates of prostate cancer. Although nowadays, incidence in the Western world seems to have stabilized or is even dropping. This is because this was the time of introduction of the testing for prostate cancer with the PSA test and things like that. So many more cancers were diagnosed at that time. So there appears to be an increased incidence. But now, once the system has stabilized with people having tests with this prostate cancer, the rates are kind of stabilized and now sometimes appear to be declining in some populations. About 10% of men will be diagnosed with clinical prostate cancer in their lifetime. So it's a significant thing for most men. And prostate cancer is a disease of old men. If you look at it, it's rare to see a prostate cancer in a man below 40, and it's higher in the 7th, 8th, and 9th decades of life. And beyond that, there are fewer people to have prostate cancer. So the incidence declines because most people are dead by that age. But after 90, most people are dead anyway. Personally, the youngest person I've seen with prostate cancer was 25 years old. But that person had a history of abuse of anabolic steroids for bodybuilding. So maybe that's something to do with his, I don't know. The prostate cancer deaths in UK is highest among the older population. This is because prostate cancer is higher in older population. And whenever an old person dies who has prostate cancer, it's always put in there one of the causes of death, maybe a death of tertiary or the fourth cause of death. So if you look at statistics, it appears that many of people die of prostate cancer are older men, but this is because these people are dying more than every other person. So they have a higher rate of prostate cancer in terms of prevalence, not necessarily that it's a clinical disease in those men. And what the other thing that I can say is that survival of prostate cancer in the UK has improved in the last, I say 20 years. And generally about 80% of men who are diagnosed with prostate cancer will survive for up to 10 years, which is a significant improvement. If you look back historically, when people had been diagnosed very late, survival was talking about 2, 3, 4 years. Now it's going up to about 10 years. So this is a big improvement from the screening and also from the active treatment people are having for prostate cancer. It is believed that if we continue on the same project that's shown, which we are doing now, that prostate cancer deaths would drop significantly by the end of the 2030s. What are the risks of prostate cancer? Like I remember there's a question earlier before about cause of prostate cancer. We don't know what is the cause of prostate cancer. Nobody can be sure what the cause of cancer. We know what are associated factors, which we call etiological factors. And first of all, is age. As men get older, risk of getting prostate cancer is higher. They think that maybe it's because of some damaged genetic cells in prostate glands over time as men get older. So generally, most people who have diagnosed with prostate cancer are over the age of 55. Next is ethnicity. Being Black is a risk factor. The highest incidence of prostate cancer in the world is among Black men in Jamaica, followed by African-American men in the US. And however, a Black man, doesn't matter where you're from, the risk of cancer is higher than anybody else. The ethnicity is less often in Asian men and Latinos. So being Black is a significant factor. Next thing is family history. If a man has had cancer in his grandfather, his father, or his brothers, that's first-degree relations, the risk of getting cancer is quite significant. And these are the men in whom we advise that they start screening themselves at an early age, maybe at about 45 years of age. Also, certain men who have relations with particular cancer of breast or ovarian cancer may be at an increased risk of prostate cancer. So if you have a relation who has had breast cancer or ovarian cancer, it may be wise to start having a screening for prostate cancer at an early age to say about 45 or 50. The other thing is weight. It says that if you're overweight in your 50s, it gives you a high risk of advanced prostate cancer. So people are advised to try and keep their weight as low as possible. Now, there are no specific symptoms for prostate cancer. So if you are worried about prostate cancer, speak to your doctor about what to do. Particularly if you're over, like I say, if you're over age 50, 55, and your family relations have had prostate cancer and you're Black. Now, things that may make you think of prostate cancer. However, if you have many of these symptoms under this prostate cancer, the prostate cancer may be a little bit advanced at that stage. But things that can make you request to have a test for prostate cancer are if you get dull pain in the pelvic region, that will have pain lower down, and they can't explain why they have the pain. It's a good idea to talk to your doctor, maybe have a test for prostate cancer. If you're having symptoms of what we call prostatism, needing to pass urine very frequently, in most people, it's due to a benign enlargement of the prostate gland, but it's the time to think of prostate cancer as well, because you're having some trouble with your prostate gland. Same thing, you're having pain passing urine, burning or weak or slow poor flow. If you have blood in the urine, the common cause of blood in the urine is cancer in the bladder. However, it's been seen to occur when people have cancer in the prostate, especially if it's getting advanced. If you start having painful ejaculation, consider prostate cancer. Other symptoms are back pain, poor loss of appetite, bone pain, loss of weight. But like I said, if you have these symptoms and that is prostate cancer is likely already advanced, at least locally advanced, not systemically advanced. So once you think you might be at risk of prostate cancer, you have symptoms, then you go and see your doctor. What doctor will do for you, first of all, is to do a digital rectal examination. That is, they ask you to lie on the bed on your side in most cases, and then they put a lubricated finger into the rectum, the back passage, and try to feel the prostate gland. They're trying to feel how big the prostate gland is, the consistency, whether it's bulging one way or the other, the shape of the prostate gland, and that will give you an idea as to what may be happening to the prostate gland. This is generally should be done by every doctor. I know that a urologist might do a better rectal examination and make the interpretation, but any doctor feeling the prostate gland frequently can give an idea. This feels a bit different from the ones I felt before. And that's another time to do a PSA blood test. This test is generally easy and safe, causing minimal discomfort. It does not diagnose cancer. It simply says that there may be a need to do more tests in most people. However, in people with advanced cancers, this may be enough to say it's likely there's cancer here. And then you have to go on to try and make a diagnosis in those people. The commonest test we use for prostate cancer diagnosis is the PSA blood test. PSA stands for prostate specific antigen. This is because this antigen only comes from the prostate gland, nowhere else. Now, unfortunately, the test for the PSA can only detect PSA at a certain level. So most tests will say PSA level less than 0.01 or something, 0.03. Doesn't mean that there's PSA, just means that that's as low as the test can test. So if you take a blood for a female and send it for a PSA test, they'll give you PSA less than 0.01. Doesn't mean the female has PSA, just means that's how sensitive the test is. So we're looking for the PSA blood test. It's done in anybody can do a PSA test in general clinic. Simply take a blood sample, put in a bottle, send in a request, and wait for the results. Generally, PSA blood test results can be gotten within a few hours. However, because of course, I know that in Nigeria, many hospitals do back their PSA tests and may have to wait a day or two to get your result. That's not a problem because prostate cancer develops over many, many years. So a delay of 1 day or 2 days, 3 days here and there will not make a difference to the outcome. So don't get panicky if your results takes a week to come back to you. If your PSA level is raised, you may need to have more tests, and especially a biopsy. A biopsy is simply a test to get a sample of the prostate, preferably from areas considered abnormal, to try and have a look at it under the microscope to try and make a diagnosis. Having a biopsy is associated with some risks. It's painful. You don't want anesthetic, but most of them don't look at anesthetics. Some find it uncomfortable. The commonest biopsy still done in Nigeria is transrectal biopsy, and that's associated with a significant rate of infection in some people. Up to 3%, up to 6% of them will get infection. After the biopsy, you can have bleeding in the urine or in the semen for up to 6 weeks. That's normal, that's expected to have, that's nothing to worry about. Also, if you have a PSA test and it's normal, you can still have prostate cancer. So, and if your prostate gland is abnormal, feels abnormal, and the PSA test is normal, your doctor must ask you to have a biopsy if they think there's a chance of cancer there. So don't say because my PSA is normal, I can't have it. If your doctor advises you to have a biopsy, by all means, take the advice and have a biopsy. But bear in mind that biopsy simply says there's cancer here. So you can diagnose a slow-growing cancer, which may not have cost you probably in your lifetime, and we'll come down when we come to talking about treatment of prostate cancer. So not all prostate cancer diagnosis are things you worry about. Before you have a PSA blood test, if you just feel like having a PSA blood test, talk to your doctor. Say, I would like to have my PSA checked. What do you think? And they go through a discussion with you about the PSA. The reason for this is that PSA blood test is not a perfect test. It's good at picking up prostate cancer when it's there, but you cannot tell you haven't got cancer. That's one important thing. So if your PSA is normal, doesn't mean you do not have cancer. Also, if your PSA is high, you may not have cancer. But most people who have cancer, their PSA will be raised, many of them. If you are old, over 75, having a PSA test is of no benefit to you, because even if you had diagnosis of prostate cancer, nobody will offer you major treatment for prostate cancer. So in that case, it's not justifiable having the test to diagnose prostate cancer in an older person. Also, before you go to have tests for prostate cancer, you have to understand that treatments of prostate cancer can significantly affect your quality of life. If you want, read about the possible effects of the treatment in advance before you even have the blood test done, if you are so concerned. I'm saying this because I have a patient in Nigeria who I diagnosed prostate cancer, put him on treatment, he's fine, he's been okay for, last time I saw he was okay for about 8 years later. But he said the hormone treatment is making his testis penis smaller, so he doesn't like it to have a small penis, so he can't have sex the way he wants to. So he told me he wanted to stop the treatment because he doesn't like the side effect of treatment. I told him, well, that's your choice. It's a question of your life or sex. You make a choice. That's a personal choice. I can't make a decision for you. If that's what you want to do, you're an adult, you know what you're going through, but understand that the cancer may come back if you stop the treatment and make a decision. So these are things you have to bear in mind when you're having prostate cancer diagnosis and treatment. Now, if you have a PSA that is raised, we talked about the biopsies, and generally most places now, when you have a raised PSA, the next test you're going to have is an MRI scan of the prostate gland, and it's called a multi-parametric MRI scan. I'm going to try to explain what it means. The MRI scan normally just puts you through a scanner, which uses some adjustments of the magnetic field, get some images. But in the multi-parametric MRI scan, they have to inject you with some contrast, some X-ray, what we call X-ray dye, some contrast. and take the pictures before the injection, after the injection, and see how the contrast is washed out. That gives us a full idea. So the MRI scan has to be done by somebody who normally does MRI scan of the prostate gland. You can't just walk into a general MRI scan, have an MRI scan. It may not be useful. I see many results again from Nigeria where they have an MRI scan of prostate gland. Reporting is different from what I'm used to, so I don't understand it. So if you want to have an MRI scan of prostate gland, make sure you're going to somewhere where they have experience with MRI scan of the prostate gland. If you're going to have a prostate biopsy, in the Western world, the choice of how to have a biopsy, there are 3 different ways. There's the transrectal, which is done occasionally, which is pictured here, where you put the ultrasound probe through the back passage and put the needle through the probe and get a sample from the prostate gland. Because you're putting the needle through the feces, there's risk of infection from the biopsies, but it's not as high as people would expect. I say it's about 6% significant infection rate. So 94% of people will go not having a significant infection. So it's still a useful test if there's no other alternative. The next is a template biopsy, which involves special ultrasound machines. And with that, you need to have that's the one here. So let me go to, first, next is what we call LATP, local anesthesia transperineal biopsy. So in this one, you put the ultrasound probe through the rectum to show you the prostate image on the screen, ultrasound screen. Then you put the needle through the perineum, that's the area between the 2 legs and behind the scrotum, not through the anus, into the prostate gland to get the biopsy. By so doing, you avoid the risk of infection, but it means that it's more painful. So you are required to have either general anesthesia or local anesthesia to the perineum to have the biopsy done. But this biopsy reduces the risk of infection because we started doing it while I was still working in the hospital during the COVID era, because nobody wanted to be in hospital during the COVID. So I want to make sure I have a biopsy that will keep you out of hospital. So we switched to transperineal biopsy, and that has remained ever since. Final biopsy is what's called a template biopsy. For people who find the transperineal or transrectal biopsy too painful, they would be required general anesthesia. They are put to sleep, and again, put the probe through the rectum, and then there's a grid, a template grid put over the area between the scrotum and the anus. From there, you can map around where the prostate is within the area, and then put needle into different parts of the prostate gland. This allows you to have a more detailed biopsy of the prostate gland, because patients that sleep doesn't feel anything. You can take as many biopsies as you want. So people have taken up to minimum number of biopsies taken is about 24. Some people go as high as taking 60 biopsies on the prostate gland, just to try and make sure they can diagnose the cancer if it's there, because it's pain-free as patients under general anesthesia. I'm not sure this is available in Nigeria at the moment. I just know that most places in Nigeria have got transrectal biopsy. Now, transperineal biopsies, if you're introduced in Nigeria, it's fairly simple, although the devices for guiding the biopsies can still be a bit expensive. Some of them cost about £150, and £150 in Nigeria at the moment is nearly 15,000 naira. So people will not be willing to 150,000 naira. That makes it more difficult to accept it. It'd be expensive. So the transrectal remain the main biopsy in Nigeria for now. Now, when you take the biopsy is sent off to the lab for analysis. And if cancer is present, the pathologist will say that it's prostate cancer here. Once the cancer is diagnosed, then we have to assess the cancer for 2 things. One is, what is the nature of the cancer? And to what extent has it spread within the prostate gland? This is what you can tell from the biopsy, not from anywhere else. And then this is followed by what we call the staging, which is how far is cancer spread in the rest of the body. In terms of grading, we use what is called the Gleason score, which is trying to predict how the cancer is likely to behave, the risk of it spreading quickly. That's what the Gleason score is supposed to do. Now, the Gleason score is different from other cancer scoring methods, because in most other cancer scoring methods, if you remember the one that's shown by Dr. Jiko to you, showed the cells, the big cells with a big nuclei, which is the abnormal cells. In Gleason scoring, we don't look at individual cells. We look at the whole prostate screen and see how are the cells are arranged to give us an idea about it. If the cells arrangement is close to normal, it's given a score of 1. Normal is given a score of 1. Close to normal is a score of 2. And if it's very abnormal, it's given a score of 5. So you get a score of 1 to 5. Generally, 1 and 2 are not considered to be cancer. Cancer is Gleason score 3 to 5. The other thing is that prostate cancer does not look the same all through the whole biopsy. You can find different arrangements of the cells in different parts of the biopsy. So we have to do this scoring in 2 parts of the prostate, the 2 most common appearances, and give them a score. So prostate cancer scoring will give you a score as Gleason score A plus B is equals C. Now, if A and B are 3 plus 3 equals 6, it means a low risk cancer generally. If the Gleason score is 3 plus 4 equals 7, or 4 plus 3 equals 7, it makes an intermediate risk cancer. However, 4 plus 3 is worse than 3 plus 4, generally. If you have a score of 4 plus 4 and above, we give you a total score of 8 to 10, that is the high risk cancer or high grade cancer. So cancer, Gleason score total 6, 3 plus 3 is 6. There's no desperate need to treat the patient immediately. 7, patient should be treated and you likely get a good result. But the patient wants to wait, that's okay, wait for a while before you have treatment. But Gleason score 8 and above should be treated immediately. You can't afford to wait because it's a high risk cancer if it hasn't spread already. Then we go to the staging. We try to see how far has the cancer spread. First of all, what we call the T score, which is tumor score, which is how far has the cancer spread within the prostate gland itself. Now, if when the doctor examined you, the prostate feels normal, but biopsy shows prostate cancer, most of the cases will be a T1 tumor. If the prostate gland feels abnormal and the biopsy is positive, but the abnormality feels inside in the middle of the prostate gland, that is a T2 tumor. If the cancer is coming up the edge of the prostate, that's a T3 tumor. And if it goes outside the prostate gland, it's called a T4 tumor. So you have a T1 to T4. Next is what we call the N score, which is any lymph nodes involved. And basically, if it's either you get node involvement or no node involvement, there are different levels of node involvement. But once there's node involvement, the cancer has spread anyway. So it doesn't matter what level it is. It means that you may not be able to have certain treatments if nodes involved, depending on how far the nodes are involved. Then the metastasis it means that the cancer has spread somewhere, this time from the prostate. So prostate cancer diagnosed the amount of pain in the back, and they find prostate cancer in the back. That's metastatic prostate cancer. That's called as M1. So the M is either 0 or 1. M0 means no metastasis. M1 means there's metastasis. So prostate cancer in the bones, in the liver, in the lungs, as M1. Generally, prostate cancers are better treated when they are confined than when they are spread outside the prostate gland. That applies for every other cancer, because once cancer is spread beyond the primary origin, then it becomes more difficult to treat. Now you had a treatment, you have had a investigation, diagnosis, and the cancer has been staged and graded. Next thing is, what treatment can you have? Now, generally, if a patient has a T1 cancer and low grade, no immediate treatment will be necessary. But generally, we have to look at the stage and the grade of the cancer. Look at, is this a low risk cancer? Is it intermediate or high risk? The person who has the cancer, have to look at the person as well, because a man who is very unfit, say a man who has had 4 heart attacks, has prostate cancer, You can't put him through surgery, he will die during the surgery. So such a patient, you don't offer him radical surgery. If a patient is very old, 80 years when diagnosis is made, if they made a diagnosis, you don't offer them surgery. Also, you have to think of what does the patient want as treatment goals. People have different goals because prostate cancer can significantly impact on quality of life. The patient has to decide what treatment is best for them. It's not for the doctor to decide. I know some people find it difficult when the doctor says, you've got prostate cancer. I go through all these stories about what can be done with prostate cancer, but they don't tell you what to do. They say you have to decide. The reason for that is that prostate cancer can significantly affect your quality of life. And it's for you to decide what quality of life alterations you can live with and be comfortable with. Nobody can decide that for you. So when you get the diagnosis, think about the range of treatment or choice you've been given. The doctors will give you information leaflets about different treatments. They give you information about prostate cancer itself, different treatment called watchful waiting, active surveillance, hormone treatment, surgical treatment, different kinds of surgical treatment, and all that. Give you all the information to read. It's a lot of work to do, but bear in mind that prostate cancer in most people that develops over many, many years. So even if it takes you a month or 2 months to read through and make your mind up on what treatment you have, that's fine. Don't rush into a treatment and come and say, I should have had treatment if I knew. So think about it properly, read around it. If necessary, at least in the Western world, you can be put in contact with people from prostate cancer support groups. You can talk to people who have had different treatments, surgery or radiotherapy, and see what the experiences have been, and then make up your mind at that point. Don't go and ask your doctor to decide for you. Don't let the pastor tell you what to do for your prostate cancer. It is your decision how you treat the prostate cancer because you are the one to live with the consequences. Now, while you are doing this, always bear in mind the changes that may occur in your life, immediately after treatment and long term. You may, if you are considering having surgical treatment and radiotherapy treatment, ask for an appointment to speak both to the surgeon and to the radiation oncologist to help you decide which treatment, which way to go. Also, if you're going to subject yourself to surgery and even different treatments, find out about the experience of a doctor who's treating you. How many of these have you done? What are your results? Because incontinence is a significant problem. So make sure you ask the doctor, what's the incontinence rate in your patients after this surgery? And not just doctor, ask people in the team, other people in the team, the incontinence rate, because sometimes people overstate how good they are as surgeons. The other people in the team will give you a better assessment on what to expect afterwards. So it's important to know how good the surgeon is, how many they've done before they do that. And because it's going to be a big treatment, do your best to try and get healthy while you're waiting to have your treatment. So reduce your weight, improve your fitness, take walks. If you're able to jog, take a run, whatever exercise you're happy with. Try and do that quite often. So the next slides we will now discuss will be the treatments that will be available to you for prostate cancer. First treatment method we call active surveillance. Active surveillance is for people who have got a small, slow-growing cancer. And you've been diagnosed with cancer, you're told your cancer is Gleason score 3+3. It only involves about 5% of the prostate gland, 10% of the prostate gland. This is a small area of the prostate gland with a low-grade tumor. If you are, say, even if you're 60 years of diagnosis, you might go another 5, 6, 7 years without having significant harm from this cancer. Now, the reason for this is that prostate cancer can significantly impact your quality of life. For instance, a man may have prostate cancer, become incontinent, lose his erection, and that man may feel that quality of life is very badly affected. If you go for active surveillance for low-grade cancer, you can have normal erection and normal continence for another 5, 6, 7 years before you have to come to active treatment. And it is shown that this does not in any way disadvantage you when you have treatment eventually. And many men can go and never have treatment in their lifetime. I've seen patients who have got a PSA and remains around 3.5, 3.6 for many, many years. After a while, it's passed them back to their GP or monitoring, stop seeing them in the hospital because there has been no progression of their cancer. So it's possible that that works some people. Now, if you're on active surveillance, it doesn't mean you're left with no treatment. It means that you will see your doctor frequently from time to time. First for urologist, you'll be seen by a urologist. You will have a blood test every 3 months for the first couple of years, seeing whether your PSA is increasing or remaining stable, how much it's increasing. And in between, you're going to have examination of your prostate with a finger in the back passage. And if necessary, you may also have an MRI scan. If PSA is rising, you may have an MRI scan. Sometimes you may be advised to have a repeat biopsy in case the biopsy, first of all, made the wrong assessment. So this is all part of the active surveillance. But the reason for, ultimately, for those for whom it's beneficial, they can avoid mutilating treatments and not have to have treatment at all, or defer it to a later date, much later date. Next is what we call watchful waiting. If you diagnose cancer in an older person or someone who is very unfit, not fit for any radical treatments, and they're having no symptoms for the prostate cancer, then sometimes it's felt that it's better to leave them alone, having no symptom, because treatments you're going to give them will change their quality of life. They will have side effects from the treatment. So if they have no symptom from the prostate cancer and you have not planned to treat them with any radical curative treatment, then such patients can simply be monitored on a regular basis. And then if they become symptomatic in future, they're given palliative treatments, which is treatment designed to slow the cancer, but not to try and remove it completely. And that means that an 80-year-old man, a 75-year-old man can be pushed on to goes on to 85 by the time they have significant symptoms. At that point, many people are happy they've had a long enough life, rather than to live with the consequences of the treatment. So it's a one-way treatment of managing prostate cancer in older people who have had cancer diagnosed, but who have no symptoms from the cancer. If you want to go for curative treatments, and if you want to put the curative treatment in parentheses, because we cannot cure cancer, we can have long-term survival of after cancer treatments. I've seen a patient who had a cancer treated after 20 years. He was fine, then he came back in his big toe. So nobody can ever say you are cured of cancer. We can say that you are cancer-free. We say 1 year, 2 years, 5 years, 10 years cancer-free survivor. We don't say cured. However, the longer you are from treatment without having any recurrence, the more likely the chance of being actually be cured in the long term. But nobody ever says your cancer is cured. So in terms of cure, we have two choices, either surgery or radiotherapy. Now, surgery, the commonest surgery done in Western world now is robotic assisted laparoscopic radical prostatectomy. That means that the patient has the operation done with robotic assistance. If I go to the next picture, that is how it looks. If you look in this image, this is the surgeon here, and that's the robotic control unit. The surgeon there looking at it down to make the operation, and these are robotic arms there, and this is surgeon's assistants who can put the arms wherever point they want them to be, and then the surgeon controls it from inside that machine, and that helps you to operate to remove the prostate gland. This means that you have to make multiple incisions lower abdomen, I think it's about 5 small holes to put the camera and put the operating instruments. The beauty of this is that because it's a robotic machine, you can make the arms go into sorts of positions to give you what you want, which you cannot do with a human arm, because you cannot, there's a limit to the motion of range of movement of human arm. So the robotic gives you a higher range of movement. And so they're able to do the surgery more effectively in those patients by having robotic assistance. So the surgeon will control the robotic arms and move it very precisely to do the surgery. Next is the original one, which is retropubic open radical prostatectomy, which is you get a cord done just below the belt line to open up into the space between the bladder and the anterior abdominal wall. From there, you approach the prostate gland, and then you cut off the prostate gland, leaving the neck of the bladder above and the urethra below the tube. And then after they remove the prostate gland, join them back up to try and restore things the way they were without the prostate gland. It's a good operation, it works, but it requires a longer hospital stay, more likely to have more complications. However, it is so much better than robotic surgery. For Nigeria, I do not think that robotic surgery is really an option. The robots cost hundreds of thousands to buy, and I think the running cost for a robot is about £200,000 a year. That's about that means almost 200 million naira a year. I'm not sure how many hospitals in Nigeria can afford to devote 200 million naira just to run one machine in a hospital. And if you're going to use robotics, you have to have a backup machine. So this is a long way from getting to Nigeria if you ever get there. So that's why I say that this open to prostatectomy is still quite valid in Nigeria. Just needs to stay longer in hospital. It's cheaper. In the UK, if you come to UK to have robotic surgery, you're talking about 28,000 pounds. If you have some surgery done in Nigeria open, you may get away with paying about 5 million, 6 million naira. So it's a big difference, quite a significant cost saving for those who can afford to have it done in Nigeria. So, and outcome, it seems same operation done differently, and the results are similar. The only difference is complications are higher with open operation, hospital stay is higher. Next, laparoscopic radical prostatectomy. I know many people may have seen someone showing a video in WhatsApp about Nigerian who came and did the laparoscopic prostatectomy in Lagos, some Nigerian surgeon based in UK. That's fair and good. You can go and do 1 or 2 operations if you do a medical mission, but you cannot treat everybody with those medical missions. So if we cannot afford to have laparoscopic surgery in Nigeria, robotic surgery in Nigeria, maybe you can afford laparoscopic surgery. But this means that the governments and the healthcare system have to invest in training people. The surgery is just like robotic. It just goes through small incisions in the abdomen below, but it's controlled by the surgeon that using their hand directly to hold the instrument, not with the robotic assistance. And like I say, it's expensive, so I'm not sure it's going to be available in Africa for a long time. It may be available in small patches, but not widely available. And so my view is that if you want to have minimal access surgery for prostate cancer in Africa, we should arrange to get people trained in laparoscopic prostatectomy and make them come back to practice in Nigeria. It's okay to send someone to go and learn a skill. How do you make them come back when they've learned the skill? That's the problem. I know that very smart legislators are trying to make a law of imprisoning doctors in Nigeria, forcing them to stay, making them state prisoners. But that does not work. If you send someone to go and learn new skills, and he has got the skills and he can make a better living elsewhere with those skills, unless you can give him a fairly similar living to what you can get elsewhere, most people will not come back. So I know it may sound crazy, it may sound difficult, but they have this point for Nigeria to look at paying people in the healthcare industry a bit more to discourage them from leaving the country. But that's a different matter. That's not part of my talk. If you have had discussion and you don't want to have radical surgery because you don't know not happy with the side effects, the next alternative for you is to have radiotherapy, which is done in one of a few ways. The standard treatment is what we call the external beam radiotherapy, which is a targeted beam, X-ray beam, is used from the outside of the body and aimed at the prostate gland. This is the patient. Prostate gland is somewhere around here. So they put this machine over the area of the prostate gland. Patient lies still. Then this bit of the machine, which is the treatment head, will go around in circles all the way around, and it goes 360 degrees around the patient, irradiating the patient from different angles. That is because you want to avoid damage to the structures above the prostate gland in an attempt to treat the prostate gland. So going from different angles, different places, give it treatment, means that you get the maximum irrigation to the prostate gland and less for the surface of the body. And this is that's the whole idea of treatment. So it's radiation. Most places it's going to be given in fractions. That's going in bits, either in 4 fractions or 20 fractions to the 8 fraction, depending on what kind of treatment you're having. But you're going to go to treatment and keep going back until the treatment is completed. The commonest method is to go every day, Monday to Friday, for 4 weeks. That's 20 treatments. So if you are working, you know you have to take out time off work to have the treatment. However, if where you work and where you have treatment is near enough, you can go to treatment and go to work, because when you have the treatment, you don't really feel nothing until somewhere down the line, if you have a side effect, then you can take time off work. There are other newer methods of giving radiotherapy, something called the conformal radiotherapy, which the whole aim of all this is trying to reduce the amount of damage to the structure around the prostate gland. So the conformal radiotherapy, the proton beam or stereotactic radiotherapy, they all try to focus the treatment only around the prostate gland, so to reduce irradiation elsewhere. This is helped by this modern CT and 3D reconstruction, so you can carefully map out the area of the prostate gland, so you can deliver the maximum dose to that area. And that's it. When this treatment is completed, the patient's PSA initially will rise because of damage to the prostate gland. PSA rises. But eventually, once the treatment is completed, PSA will drop to a particular level. That level is what we call PSA nadir. So that's person's basal PSA after treatment. Generally, this happens about 3 to 6 months after the treatment is completed. Now, if that PSA level is maintained for a year, 2 years, 3 years, it means that treatment has been reasonably successful. But you have to keep checking the PSA long term. If the PSA starts rising, it means treatment has not been successful. So you have to think again about what else to do. There's also brachytherapy, which is where the treatment is given with radiation, but given from inside the body rather than from outside. The radioactive material is placed inside the prostate gland, either with needles or a tube, and then the radiation comes from inside and going outwards. There are 2 types: low dose brachytherapy or high dose brachytherapy. What happens is this patient gets radiation from the inside, and if you are a grandfather, at that point, you're advised not to sit your grandchildren on your laps for at least 3 months or 6 months after the treatment is completed, because they will get irradiated by the seeds implanted in prostate glands. So this treatment, after about 6 months, all the radiation has worn out, so it become inert. But in some of them, where they have permanent implantation of seeds, the seeds remain in the body after you can't remove them. Many of this treatment, because you're going to have to stick things in the prostate gland many times, it requires anesthesia, and sometimes also maybe a short substitute a day or 2, because having passed the needle through the prostate gland so many times, put the radiotherapy material inside, the prostate gland will swell up, and some people may have having difficulty passing urine. So this is why sometimes you have to spend some time in the hospital if necessary. Now, quite often, radiotherapy is combined with hormone treatment to shrink the prostate gland size to have a small target to treat. If you imagine that a man's prostate gland was, say, about 100 grams, the effective volume they want, if possible, when is about 25 grams. So you need to, if you give hormone treatment, you try to shrink the prostate gland down to a smaller size to make it more effective. So if you offered hormone treatment before radiotherapy, that's normal. That's just to reduce the volume, prostate volume, for when you have the treatment. There's also something I missed out is the chemotherapy. Sometimes if you have got locally advanced prostate cancer, so T2, T3, with no ovarian metastasis or with very few metastasis, you can give the patient, in addition to the therapy, you can also give some chemotherapy as well. Chemotherapy is supposed to mop up any lesion that maybe has spread to the lymph nodes or to the bloodstream, if they are not, even if they're not obvious at that point. So you can give chemotherapy. But this method is normally used more in younger people. If you have a younger patient with prostate, say 55-year-old man with prostate cancer, local advanced, we will try to throw everything at the patients, like say throw the kitchen sink at the cancer. So we give radiotherapy, hormone treatment, and chemotherapy. And the common chemotherapy given is some drug called docetaxel, which is given intravenously. And unfortunately, people who have treatment will lose their hair, but the hair grows back. Now, there's other forms of local treatments, but these are all under studies, experimental focal therapy. There's HIFU, which is high intensity focused ultrasound scan. This has been around for many years. It's been around many years. Hasn't never become standard treatment because it's not producing wonderful results. Also, there's cryoablation, which is freezing the prostate gland. In the past, they used to do total cryoablation of the prostate gland to destroy the whole prostate gland, hoping to kill the cancer. But the complication rate was high in terms of people getting fistula, that holes into the rectum and all sorts of things. So now they're trying focal cryoablation, which is trying to target the cancer after a mapped out MRI scan and things, and it's only freezing the area of the cancer. The results are still awaited, long-term results are still awaited. There's also what they call the nano knife, which is basically the same thing, trying to treat the focal. These are all treatments. These are all still experimental treatments. They're not standard treatments. Now, for people who have got advanced cancer, the mainstay is hormonal treatment. And there are two options: surgical castration or medical castration. Surgical castration cut off the testicles, because hormone testosterone comes from testicles, and once testosterone is taken away, the prostate cancer shrinks in size, does not go completely big, shrinks in size, becomes slow, doesn't grow as fast, and that can give the patient many years of symptom-free survival. But it's at the cost of having no testicles. And I think in our African culture, where people think they're going to come back to life, they don't want to come back as men don't want to come back alive as females, so they don't want to have their testicles removed. So generally, most people in Africa will refuse to have orchidectomy. Luckily, the medical castration is as good as surgical castration, just more expensive. Because surgical castration, you have an operation, pay a hospital bill once and go home. That's it, all done. You don't have to remember to have your tablets or have your injection or whatever it is, just a one-off treatment. It's all done and you're gone. With medical castration, you have to have tablets or injections on a regular basis to keep the testosterone suppressed. It still suppresses testosterone levels with very, very low levels, but in theory, it's reversible. If you stop the treatment, things should go back towards normal. How normal it becomes after that, nobody's sure, but it could go back towards normal. These are the two main things for the hormone treatment of prostate cancer, surgical medical castration. Then beyond that point, you can have other medications because medical castration, surgical castration, on the average, lasts about 3 years before the PS starts rising again. So when it starts rising again, the other treatments you can give, that the androgen blockade and different other medications. But I don't think the technical part is necessary, just that there are many more drugs like abiraterone, things they can give to help to improve the symptoms. These are all palliative treatments, just designed to slow down the growth of the cancer and give the person some more symptom-free periods. That's what it is. Now, prostate cancer can significantly affect quality of life. So you have to bear this in mind before you start treatment. Now, once you finish your treatment, you're going to have to live with the side effects of the treatment. Most men will have sexual problems after a cancer treatment. Many surgeons will tell you that their patients have, or the impotence rate is only 10%, it's a lie. The impotence rate in people who have prostate cancer surgery is 100%. However, some men recover some degree of potency afterwards, but most men who have this operation are required to have treatment for their erectile dysfunction, either the tablets or injections, Viagra, and things like that. So if you're going to have surgery for prostate cancer, understand that you're going to require treatment for erections afterwards. It's most likely. So shouldn't come to you as a surprise. It's part of the process. However, the risk of erectile dysfunction can be affected by the age, the patient's overall health, and what other medications you take, and how sexually active you were before. And then also the cancer stage and different things. The truth is that most men who have prostate cancer are above 65, going 70s and 80s. And people at that age have declining sexual function anyway. So the risk of erectile dysfunction is amplified by their age. But so it's something you have to bear in mind having these treatments. whatever treatment you have because of erectile dysfunction. Also, there's an incontinence rate after surgery and occasionally after radiation. Luckily, the incontinence in most people is transient. The total incontinence rate is transient. But quite stress incontinence, which is a bit of leakage when you do something strenuous, happens in many men, even after many years after the treatment. So, but that's easy to manage. But bear in mind that there's a small risk of total incontinence having surgery, and it's about somewhere between 2 and 5%, depending on your surgeon. And if it happens to you, you have to accept it's part of the process. Other things that you may need to make some lifestyle changes generally, which is good for everybody health-wise. So change your diet, plenty of fruits and vegetables, eat high fibers, low-fat foods, cut the amount of refined sugars in your diet, and also avoid processed food where possible. These are all general health things, but they also claim it helps prostate cancer. Exercise as well. It improves your physical and emotional health. It reduces anxiety, gives you more energy. You feel you're doing something, you watch yourself lose some weight, improve your self-esteem. You feel more hopeful because you're feeling well and your heart is better. So generally, after this kind of major treatment, it's good to have regular exercise as much as you can tolerate. It boosts your muscle strength, helps you maintain bone health. It's important to put regular exercise into your recovery plan. That's it in a nutshell.
Thank you so much for that very detailed presentation. We have a few questions for you. Ajayi is asking, has said that he often sees on the internet all manners of adverts for promoting the use of herbal remedies for prostate cancer. How efficacious are these remedies? And is it advisable for patients to resort to these traditional remedies?
Herbal remedies, unfortunately, are not licensed for what they are claimed to be. And you can bottle whatever you want and say for prostate cancer. No law regulating that. So generally, those herbal remedies are as good as shaking the hand of your reverend father every Monday as part of treatment of a prostate cancer. There's no evidence. So don't waste your money on those herbal remedies. Don't work.
Great, thank you. Helen is asking, are Blacks more likely to get these cancers because of our diet, or is it the weather? Our weather?
I don't think it's the weather, because it's difficult to say, because Black people in Africa have a lower incidence of prostate cancer than Black people in America. I think people think it's genetic and also dietary and lifestyle. But I think the genetic is a big component of it. Generally, Black people are supposed to have higher testosterone levels than most other races. So maybe that's linked with, nobody is sure, but it's just been shown that prostate cancer is highest in Black people, and highest in Black people living in the Western world, and higher than those in Africa. Having said that, though, Black people in Africa don't have so much screening done on them, so maybe it'd be higher if you do a screen in Africa. So nobody's sure about that.
All right, thank you. All right, Helen is asking again, is prostate cancer directly related to an active or inactive sex life?
There is no evidence that sex, one way or the other, affects prostate cancer. What is clear is that you have to have testes, have prostate cancer. If you're cut off a testis at birth, the person will not have prostate cancer. But if you have testicles produce testosterone, you have a risk of prostate cancer. There are all sorts of things people say that it's associated with having no sex, having sex. No, but there's no evidence to back any of that up.
All right, Helen, I hope that answers your question. Another question is, what kind of test do you advise in the case of men above 75, since you said routine PSA testing should be avoided?
If you're a man above 75, if you're very fit, you can have a PSA test. Trouble is that when you now come to having treatment, not many people offer you surgical treatments at 75. So if you're now gone through having a biopsy, having everything done, and they come and say, okay, now you've got prostate cancer, but you got to live with it. We're not going to treat you. Then what's the point trying to find out? But if you're very fit and you can afford surgery, some people might offer you surgery, but that's not common. In the NHS, it'd be hard to get surgery if you're above 78. It'd be near impossible. So this is why we say at that age, there's no point, because if you have prostate cancer diagnosed, most likely they're going to put you on watchful waiting. So why go through the pain of having diagnosis made? But if you are at those ages and have symptoms, yes, by all means, to do a PSA, because you may have symptoms of advanced prostate cancer, you may require treatment. So it's just that we don't recommend PSA screening for who under 75, not PSA screening.
Okay, that was the next one. What is the minimum age to go for PSA? Someone was asking that actually.
It depends on your family history. If you have got so many first-degree relations who have prostate cancer, I would say 45. If not, and you're black, I'll say 50.
Okay. And what is the normal PSA level, and how often should one go for the PSA test?
The normal PSA level is age dependent. But as a ballpark figure, PSA of about 4 is normal. Above 4 is abnormal. However, your age, if you are 40 years old, they say your PSA is below 2.5. If you are 50, below 3.5. If you are 60, below 4. But the upper limit of normal prostate is about up to the age of 70 is about 4.5. Above 70, take it up to 6.5. So it depends on your age. But generally, PSA above 4, you have to talk to your doctor.
All right. Okay. Our next question is for Dr. Tricia. Do you want to raise your hand and I can ask you to unmute and you can ask your question, please? Tricia? Do you raise your hand and I can see where you are and ask you to unmute? No? All right. Okay. She says in the chat, osteotomy also causes profound severe osteoporosis. That this is important to know as a consequence of the procedure. What is the procedure?
Osteotomy removes testes and lowers testosterone levels. So yes, there's a risk of osteoporosis. However, if you remain active and using their legs and bones, then risk of osteoporosis becomes a lot less. And you can, there are medication you can take if the osteoporosis comes in. It's a question of balancing one for the other. If you require treatment, if you don't have a treatment, cancer spreads. So you have to have a treatment. And if you get osteoporosis, that will be addressed.
Right. Okay. Okay.
But like I say, maintaining regular exercises means maintains your bone mass. So if you're lifting weights and taking long walks, running and jogging, osteoporosis is less likely to happen.
All right. Thank you. What impact does lycopene from tomatoes have on prostate cancer risk?
No evidence. People are claiming that eating tomato prevents prostate cancer. There's not been showing evidence. However, tomato is a vegetable. It's good for you. So if you like it, eat as much as you want to eat.
All right. Thank you for that. If you have any more questions, just raise your hand. And then we can take a question, or if you have a comment or you want to contribute. Helen, do you want to raise your hand and ask your question? This is an interactive session, so let's hear from some of the audience. No? Okay, Helen, unmute yourself. Thanks.
Okay. Thanks, Akbakama. Will most men have large prostates in their lifetimes? And how does this relate with getting prostate cancer?
Prostate begins to enlarge in almost every man from age of about 40. So most men above 50 will have a large prostate gland. However, that is benign prostate enlargement. It has nothing to do with cancer. Cancer does not make prostate grow. That's not what causes enlargement. It's just age. And there's no association between a large prostate gland and prostate cancer. So prostate cancer comes to people who have large and small prostates.
Helen, does that answer your question? Okay, looks like Helen is gone. All right. Anyone else have any questions?
Yes, it does. I was trying to unmute myself. Yes, it does.
All right. No problems. Okay. Hakim, do you want to raise your hand and ask your question? And Jolie as well? Raise your hand and I can unmute you. Everybody's shy today. What's happening? Okay. Hakim is asking, does diabetes increase your risk of having prostate cancer?
No, it does not. However, there's a small big association between obesity and prostate cancer, and obesity and diabetes go together as well. So theoretically, it's maybe a small chance, but it's not significant.
Okay, back to diet. Are dairy products and red meat, could they contribute to the risk of prostate cancer?
Nobody's sure. But people will say that if you look at prostate cancer, is less common among people in Japan and Asian cultures, and those who eat less of red meat eat more of fish and meat. So people say maybe it is, but nobody is certain. But generally, red meat and a lot of things with fats are not good for you anyway. So if you can avoid them as much as you can.
All right. Oh, Helen, you've got your hand raised. Okay, unmute yourself.
Okay, so another question about the enlarged prostate. Are there vitamins, are there medication that people take to reduce them?
Yes, there are herbal kind of over-the-counter remedies you can buy, things that contain saw palmetto. This can reduce prostate gland size and make symptoms less. That's about the only thing that's effective that people can buy, saw palmetto. The many other things people put on the shelf, that's not shown to work, but this is shown to work some people.
Okay, thank you.
All right. Greg, unmute yourself and ask your question.
Yeah, I just want to ask this. Sometimes when you look at the social media, you find people giving testimony of using some maybe soursop, beans, and not eating sugar help to cure prostate or prostate cancer.
Okay.
How good evidence is this in terms of your own experience?
What I'll say is that as long as you have the medical treatment for prostate cancer recommended for you, whether it's surgery or therapy, any alternative you want to add to it, fine, but don't go for alternative treatments and not have treatment you are given. Diet soursop does not cure prostate cancer, but because that this in media, soursop helps cancer. So people who have got cancer buy it and take it. And when they get better, they say because they took it, but other people who didn't take it also got better. But like I say, if you believe it works for you, it doesn't do any harm. So by all means, take it. I'll give you an example. When I started many years ago, a patient came to me and said that there's one chap there called Richard Lane who was selling some treatment for prostate cancer, which is shark's cartilage from sharks. The base of this treatment was that in nature, sharks do not develop cancer. So he said that maybe there's something in sharks that gives them protection from cancer. Looking at sharks and other fish, the main difference is that sharks are cartilaginous fish. So he started grinding the shark cartilage, put in bottles as treatment for prostate cancer. So a patient came to me and said, should we take it? I said, look, if it's chest cartilage, it's not going to kill you. It's not going to. If you want to try it, by all means, try it. I'll be happy to monitor your effects if you want me to monitor it, which I did. And it made no difference whatsoever. And the patient himself stopped it. But if you won't do any harm, by all means, try whatever you want to try. If it's something dietary, some fruit, some meat, some whatever, by all means, go ahead.
Okay.
All right. Okay. Lala is asking, can someone with kidney cancer be prone to prostate cancer?
There's no link whatsoever between those two cancers.
Okay, so a question for our two speakers. Someone's asking in general, are cancers more common in blacks and why? If so, why or why not? Or do we have any evidence or information on that?
Prostate cancer is more common in blacks. That's shown statistically because incidence is higher in black people. And we think it has to do with genetics more than anything else. Maybe also diets. Nobody's certain about an environment, but I think more like with genetics. Because wherever you put a black man, be it Africa, in Asia, wherever you put them, they have higher risk of prostate cancer. Because of something inbuilt in the black man makes him higher. As far as I know, it's only for prostate cancer this has been shown, not for any other cancer they know about.
Okay, Mr. Ojuti, could any comment on that question?
Not really. I mean, just like I said, there's an interplay between biology and genetics and environmental factors. The same way thyroid cancer is more common amongst Japanese people, diabetes, where we get it more than South Asians get it more than us. So it's multifactorial. We don't just, the reason why you might have the opinion and the impression that cancer is more common in blacks is because we keep on emphasizing it in the health messages to try and get you to pay attention to them. And that's the frank truth. There are some other cancers which are not common in blacks. Can't think of any at the moment, but just like some other health diseases and disorders that are not as common in blacks. So yes, but this is what concerns us.
Great, thank you. Back to surgery again. Okay, before I ask that, Clem, do you want to ask your question?
Just a question about the best way of checking for prostate enlargement. Is a resectoscope the best way, or is there a more effective way of checking?
Prostate enlargement is a normal part of the aging process, not an illness. If you have no symptoms, there's no need to check. If you have symptoms, then an ultrasound scan is best for checking prostate size. Transrectal ultrasound scan. Okay. Also, the finger examination will give you an idea of how big the prostate might be, whether it's big or small. Can do with the finger and back passage. But if you want to know the exact size, ultrasound scan is probably the easiest way.
Okay, thank you.
All right. With regards to surgery, if a man has had laser surgery previously on prostate issues, is there a likelihood of recurrence after some years?
Laser surgery is done for benign prostatic enlargement, not for cancer. And that surgery is designed to remove the inner part of the prostate gland, which is causing the obstruction. Yes, over time, the prostate can grow back. And it could, I think that laser surgery for prostate is not been around for long enough to give figures. But if you have the standard treatment called the TURP, there's a 10% recurrence at 10 years. So surgery, laser will have a similar thing because you're not taking away the entire prostate, taking away the inner part of the prostate causing the obstruction. But that's not cancer. It can grow back and can treat it again second time.
All right. Okay. Speaking of hormonal treatments, but not necessarily for prostate cancer, Hakeem is asking, does hormonal medication used in treating infertility in men increase the risk of prostate cancer?
No. But I'm not sure. There are not many hormonal medications for treating infertility in men anyway, because most men have more infertility, unless especially have low testosterone levels. Yes, low testosterone. If you want to use testosterone as a man above 40, you must have a PSA check before you use testosterone. If your PSA is high, then there's higher risk of cancer if you keep taking testosterone. But if your PSA level is normal, they can use testosterone treatments.
All right. Okay. This is one for Mr. Jutiku. For cervical cancer detected early, what kind of surgery is advised? Or treatment?
Normally, what they tend to do they used to call it a cone biopsy. Now they call it a loop excision, large loop excision. So essentially, what they do is that area of delicate cells in the cervix, they remove it. It's a procedure that can be done in an outpatient clinic. You don't need to have a general anesthetic or anything. And then afterwards, they'll test to see whether all the abnormal cells have been removed. And it is curative to a high degree.
Okay. All right. Helen, I hope that answers your question. Right. Do we have any more questions? Please do raise your hand. I can't see many in the chat, so but easier to raise your hand right now. All right, Greg.
Yeah, one more question, please. Is it true that staying out of sugar can prevent you from cancers in general?
No, but it's shown that cutting down sugar intake is beneficial anyway, health-wise. So if you have any cancer, cut down sugar, yes, but it doesn't prevent cancer, no.
Thank you.
All right. Tony, I think you had a question in the chat. Do you want to unmute yourself and ask? Tony? No? All right. Are there any more questions? Final offering before we go. It's almost 6 o'clock. All right, Hakeem is saying in a low resource country like Nigeria, do you recommend a routine DRE or PSA for people at risk?
Even in the UK, there's no national prostate cancer screening arrangement. It is a question of individuals who assess their risk and they ask for the test. So I'll say in Nigeria, if you have a higher risk of prostate cancer, so if you have a strong family history of prostate cancer or breast cancer, and you're above 45, 50, yes, by all means, have a PSA test and get a doctor examine your prostate gland. That's the way that would be recommended.
I'm sorry, I was on mute when you called my name. I just repeated the question that was previously asked by somebody that was not answered. And the person asked, can not having regular search increase the amount of chances of having prostate cancer? I just repeated the question the person asked.
There's no evidence for that because prostate cancer happens in priests who are supposed not to have cancer. However, we know that not all priests are celibate. But even monks who are celibate, they still have prostate cancer. So there's no evidence that links sexual intercourse and prostate cancer.
Okay. If there are no more questions or comments, I will say we have come to the end. I did notice earlier on some people were putting their email in the chat. If you want the slides, you need to send an email to the Gintavenes email address. John, if you could put that in the chat again so that people can have the email address. So you can send an email to that email if you want the slides. The recording is on YouTube on our channel right now, so it should be there. I was going to post it, but I'll find it. So if there are no more questions and comments, we'll say thank you. Thank you for joining us today. And have a good evening. Have a good weekend. I will see you soon. You can unmute yourselves and speak if you would like. I've allowed everyone to unmute themselves now. We're finished.
Yeah.
Thank you very much. Thank you very, 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 very much.
Thank you.
Thank you very much.
Thank you.